to mention, he has got a number of awards. To begin with, he has got AIMS Research Excellence Award for Best Published Work in 2016, Research Excellence Award in 2015, BMJ Excellence Award in 2014, and he has been nominated for prestigious Padma Shri Award of Government of India in 2010 and 2016 twice. And under his leadership and guidance, we want to start the transplant program as soon as possible. Then we are having with us Dr. Professor Mahendra Bhandari, sir, who needs no introduction. He is at present a director of robotic surgery research and education and CEO of the Vattikutty Foundation at Henry Ford, Detroit. He has done his graduation from Rajasthan University, and he has done his urology training from Madras University. He has been a noted urologist and kidney transplant surgeon. He has led several successful innovations involving multi-institutional teams, and he has developed the techniques of robotic-assisted partial nephrectomy, robotic surgery in children, robotic-assisted kidney transplant surgery with hypothermia. And he has been twice director of Sanjay Gandhi Postgraduate Institute in 1997 and in 2001. He has been Vice Chancellor of KGMU in 2003, and he has established Indian Journal of Urology in 1984. For his outstanding achievements and for outstanding work for the community and the medical field, he has been awarded Padma Shri in 2000, and he has great interest in renal transplant and has led to creating regulations for safe donor practice. He has been member of Select Vancouver Forum for Definitive Statement for Ethical Live Organ Donation. Sir, we are proud to have you with us today evening to enlighten us in the same topic. Then we are having Dr. Professor Sandeep Guleria, sir. He is a senior consultant in GI and transplant surgery in Indraprastha Apollo Hospital, New Delhi. He has received Padma Shri in 2019 for his outstanding work in the field. He has done his graduation from UCMS New Delhi, post-graduation from AIMS New Delhi, and has been trained in transplant from UK. He has been past president of Indian Society of Organ Transplantation. He has many firsts in his names. First cadaveric renal transplant in India. He has led the team. He has led the team for first kidney pancreas transplant in India. He has set the transplant program at Bir Hospital, Kathmandu, Nepal. He has set the program in RML Ram Manohar Lohia Hospital, New Delhi. He has set a pediatric transplant unit at AIMS New Delhi and also laparoscopic donor nephrectomy at AIMS New Delhi. Sir, we hope that the name of AIMS Bhopal also gets registered in this list. Thank you for joining, sir.
Thank you, sir.
Then we are having with us Dr. Pranjal Modi, sir. He is at present professor and head urology and transplantation surgery in Institute of Kidney Disease and Research Center, Ahmedabad. He has been outstanding in the field of transplant. He has done his graduation from Jamnagar Medical College and post-graduation from same, and he has done his urology training in IKDRC, and now he has largest series of laparoscopic kidney and liver transplantation in public sector in India. He has done almost greater than 350 robotic kidney transplants. He has been instrumental in robotic kidney transplant with regional hypothermia. He has worked in retroperitoneoscopic donor nephrectomy as well, and pioneered work in robotic kidney transplant in recipient. The first natural orifice kidney transplant has been registered in his name, and that was done transvaginally and robotically and laparoscopically both. So thank you very much, sir, to be with us on this eve. I guess sir is there. Okay. Then we are having with us Dr. S.K. Agarwal, sir. At present, he is professor and head nephrology AIMS New Delhi, nephrology department AIMS New Delhi. He has done his graduation and post-graduation from prestigious KGMC Lucknow and nephrology training from AIMS New Delhi. After joining AIMS New Delhi in 1989, the Department of Nephrology has grown, and at present, the Department of Nephrology AIMS New Delhi is doing almost 140 renal transplants per year under his guidance. He has been editor-in-chief of Indian Journal of Nephrology and seminars in dialysis, has chaired Global Burden of Disease in India in the CKD expert group former council member, International Society of Nephrology. He has been chief advisor of NOTO website and convener of NOTTR, honorable secretary of Indian Academy of Nephrology, and president Institute of Kidney Foundation, Delhi. Welcome, sir. Then we are having Dr. Anish Srivastava, sir. At present, he is professor and head of urology of Sanjay Gandhi Postgraduate Institute, Lucknow. He has done his graduation from GRMC Gwalior, and I can proudly say that he belongs to Madhya Pradesh, Indore. And he has done his post graduation from the GRMC Gwalior, and he has received his urology training at HGPGIMS, Lucknow. He has been former vice president of Indian Society of Organ Transplant, former chairman of Board of Education and Urology Society of India, has publications more than 65 in renal transplantation, and in the field of urology more than 150. He has great interest in the research in basic sciences related to renal transplant and RCC. He has helped many institutes to start transplant program, and we hope that our institute also gets counted in. Next, last but not the least, we are having my teacher and mentor, Dr. Manigandan sir, with us. He has been, he is at present additional professor in Department of Urology, JIPMER, Pondicherry, and has been former head of the department. He has in his name more than 50 publications in urology. He has pioneered robotic surgery in the Institute of Pondicherry, JIPMER. JIPMER is one of the leading institutes in southern India in cadaveric renal transplant, and he has received his training in renal transplant from Spain. Actually, the Pondicherry in Pondicherry, the deceased donor transplant program is advancing with the public-private partnership, so we can get some knowledge about this also. And various health insurance programs are in active for the transplant program. So to begin with, I will not take more time. To begin with, I will call upon our respected Dr. Sarman Singh sir, Director AIMS Bhopal, to enlighten us and to put forth his words.
Thank you, Ketan. Thank you very much, and having nice word. And I'm really very happy that you could invite and you could convince galaxy of very well-known transplant surgeons. I know at least 3-4 of these very well personally. Dr. Bhandari Saab, I have been KGMC, so Georgian, and he has been in Lucknow for many. He spent almost half of his life in Lucknow. So I know his work, and many of my friends, they have been trained by him. So really, we have not met personally, but I know him very well. I know quite well Dr. Sandeep Guleria. We worked together in the same institute for many years. So thank you, sir. Thank you, both of you. I was also hoping Dr. Sanjay Agrawal, he is not seen, but he is listed here. I think he will be joining. And I am really privileged that Dr. Sanjay Agrawal and we are still working together. And we could invite him last time also because in the 6 new aims, this was our target that we can start the transplant as early as possible. And in that direction, Dr. Ketan has joined Dr. Atlani. He is the single faculty in the nephrology. And we wanted, and Dr. Sanjay Agrawal agreed to handhold him. But at that time, we were not having the facility. So now we look forward that most of the things, if we can arrange as early as possible, the designing and other parts, because it requires obviously not only surgery or the operation theaters or surgical team, but also various infrastructures. So in that case, definitely on the advice of Dr. Sanjay Agrawal, we are on the track that we will be very soon. We will be having the facility. We know that today is just the conference started. Before that, Dr. Guleria and Dr. Bhandari, they were discussing that how the things are going on, because these days everybody is concerned about these whether it is a surgical management or medical management of any disease for that matter. Obviously, the COVID is always point of discussion. it is all spheres of life and all spheres of health departments or medical departments it is affecting directly or indirectly. Otherwise, also we know that the transplants in India, they are very limited and not many facilities are available in India. The kidney transplant, which is in most of the developed world, it's commonest and it is more than 50 years old technique. But still in India, the requirement is, you know all very well that it is more than 2.2 lakhs. But we are probably transplant is being done only not more than 7,000 or so. And the situation in other organs, it is even worse. So that is really very, very important, and many prestigious lives, they are lost because they cannot have the kidney transplant therapy. And even though the government of India wanted to, and they made the first act in 1991, and they modified or amended it 2011 to make it more uh, easy, but still there are lot many problems, lot many hassles, and the red tapeism in India. It is, I would not say it is one-sided, but the government also tries to do in the best way, because if the rules are not made that strict, obviously the things can be misused, or they can be in the different directions. So both way we can say that government is also on the right path, because they also want to control the misuse of the rights of the donor. But at the same time, many times it has been seen that uh, the process is so long and difficult that many times even the genuine donors, they are not able to donate the organs. So that is really something which is very much required. And I think today we will have the discussion, and I will be very much happy to listen to all of you. Our target is that we can, if the COVID was not there, obviously my target was that by end of this year, we could start it. And I am really very happy that Dr. Manoj Biswas and Dr. Ketan, they have, they could, invite, and they could have the blessings of these, very senior people. And I request from my side also that, Dr. Bhandari, Dr. Guleria, Dr. Sanjay Agrawal, and other, they can continue helping these young team members. And maybe by this year end, we will also have more nephrologists. So the team is constituted under their, patronage. I will be more than happy to, whatsoever way the urology department or nephrology department, they come up with the proposal. And I had a discussion with Dr. Sanjay Agrawal. He was ready to help, and I request the same with Dr. Guleria, and maybe Dr. Bansal also. I talked in AIMS Delhi. So these people, they are very happy. They will be happy to handhold. The thing is that we have to gear up to that level so that they can come and they can help us. And I encourage Dr. Manoj Biswas and Dr. Ketan Mehra both, and take in your team Dr. Atlani also. And I think with that, I will like to end that, and I will like to listen that how the thing. So I will request when the speakers are talking, other than technical, Dr. Bhandari sir, I would request you that other than technique, and Dr. Sanjay Puleria and Dr. Agrawal also, he has been here, so he knows. So other than technique, what you discuss, I would also request personally that if you can guide us, that how we can, move forward, and how, to begin with, how the facility can be created. So I think with that, I would leave it to Dr. Ketan to carry it forward. And thank you very much. I will be here. Yeah.
Thank you very much, sir, for your kind words. And without wasting time, sir, we'll move on, and I would like to first welcome the chairperson of the first session. We are having with us Dr. Arneet Arora ma'am, who is Dean Academics in AIMS Bhopal, and she is a forensic medicine and toxicology expert. And then we are having Dr. Ellen Durai Rajan sir. He is my teacher, my mentor, and he is head and professor of Department of Urology, JIPMER, Pondicherry. Then we are having Dr. Ashwani Tandon sir. He is additional professor, Department of Pathology, AIMS Bhopal. So welcome, sir, and I would like you to welcome our first speaker, respected Dr. Mahendra Bhandari, sir.
Thank you so much, Dr. Ketan. Dr. Bhandari, I had a teacher-student relationship as a research scholar in Dr. Bhandari sir's project on the recurrent urolithiasis, their Oxalobacter formigens. Sir, I am glad to say that now Oxalobacter formigens is used as a probiotic for the recurrent urolithiasis, and so nice to see you. And now we are at AIMS Bhopal in the able guidance of our beloved director, Professor Sarman Singh sir. I am sure our transplant center will definitely grow up and get a parity at the national as well as international level. Without wasting more time, I like to invite my teacher, Professor Mahendra Bhandari sir. Sir, please continue.
Can you see my screen?
Yes,
Yes,
sir.
sir.
At the outset, I must thank Dr. Sarman Singh for his kind words and inviting us to establish a transplant program at the AIMS Bhopal. There are several reasons I am grateful for this invitation to Ketan and the team at AIMS Bhopal. Perhaps you don't know, Madhya Pradesh is my second weakness after Uttar Pradesh because my better half happens to be from Madhya Pradesh. So there is no visit to India I goes without I visit them in Indore or wherever they are. Second thing is perhaps those who are associated with KGMC, at least Dr. Singh and Sanjay, know that I am the one of perhaps the only non-KGMC graduate who is member of the alumnus of KGMCites. I was inducted when I was vice chancellor, so I love that institution, and it's really pleasure to talk to you all.
Wonderful.
And I can sense the passion you have about the transplant program. Now, this is something which takes my memory back to what it was in Sanjay Gandhi Postgraduate Institute. And all of you would know the institute was built in 85. And we, as first batch of 5 professors over a period of time, a few months, joined in 1988 with buildings on one side and the crates of equipment from Japanese
Sir,
government
your
on the
screen
other side.
is not, slides are not seen. Only Zoom is, we can see only Zoom. So your slides probably they are not
now
seen.
do you see? Now do you see?
Nothing. Only Zoom. Zoom logo is seen. Slides are not seen.
Okay.
I think you have to find a, somewhere in your computer. So you have to share this. The green one
No,
on the bottom.
I have shared. Yeah, now?
No. Now, yes.
Yes.
Now.
Now you can see, and
Yes.
now?
Yeah, perfect.
Yes,
Perfect.
see?
Perfect.
Okay. Sorry. Thank you very much.
Yeah.
So it reminds me of what you call, 1 minute. It reminds me of what were the days, and as you know, institute is 19 miles away from city, with practically nothing in between cantonment and all when we joined, and there was nothing. Exactly, it was a worse situation. What I learned from that, AIMS is in a much better position. There was no blood transfusion facility, there was no pathology, there was no lab, elevators were not working. in 1988 when the first team came. But only thing was, all of us were very passionate. The team we had in the institute and the department was second to none, and testimony is what you will see what they are doing now in the country. And it was 6th of July 1989, and we were having similar kind of discussions. A little bit of story would help you and answer several of your frequently asked questions. 6th of July 1989, when we were waiting for our gamma cameras in the checklist, and weekly we were having dinners rotating because there was nothing much to do. There were no patients there and no activity in the hospital, but we had dreams of starting a powerful renal transplant program. It was a passion, at the same time, a tremendous responsibility. We knew the flip side of it because a state of 120 million had never seen a viable kidney transplant program. There were sporadic attempts to do kidney transplant as a technique. But we would have, it was a question of whole institute picking up or we all sinking down. And 6th of July, we had a 19-year-old man dying not dying, becoming conscious in neurosurgery OPD, and we were operating, and there was a noise that mar gaya, and then we took the patient, anesthetist revived, and he was the first brain dead cadaver. Mind you, there was no cadaveric law in the country. There was one law passed by Maharashtra, which was defunct because assembly, it was a government subject, and until the government of India passed the law, it wouldn't be there. So it was a very big question for us, and time was against. But that is the time I realized first time the value of the team. We had a departmental meeting with nephrology and urology, with Vijay Care heading the neurology, and I mean say nephrology, and we came to a conclusion after listening to everybody in 5 minutes that we are taking this kidney out and we are going to do the transplant. Then we moved the responsibility from department to the institute, and I went to must compliment Dr. B.V. Sethi, who was always had his pen open whenever we went and saw and told him something. And we transferred this and we created a hospital management board for kidney transplant with medical superintendent has. We created a brain death committee and we had the criteria for brain death. We contacted many of you would know Mr. R.N. Trivedi, who became additional Solicitor General. Unfortunately, we lost him a few years ago on dengue. And I took RN on call and said, RN, I want to take one kidney out. There is no law. But my premise is there is no law against it. And then we'll go by land of law. He thought for a few minutes and he said, don't worry, go ahead and remove the kidney and let me see what I can. He was very powerful in the state government at that point in time. And he said that, let me think, but if there is a problem, I'll bail you out. And then he made me, because I heard the forensic expert is there is a forensic head expert in UP, and he called me and said, sir, you want to take a kidney out, let me issue you a letter from state government that you have been permitted to remove a kidney out because postmortem would be done at some other place and they will say that you have stolen a kidney. So I had a letter from state government. Here the teams, I must compliment. Anant was the main marshal who worked with the donors, took the consent. We had to convince neurologists and take 3 times. One anesthetist team was with the donor. 3 times the patient sustained cardiac arrest and they revived because neurologists wanted an EEG to be done before declaring a brain death. To cut the story short, that was the kicking off of the transplant program. The first patient was one of the worst patients who was doing on dialysis, and the family was just wanting to take a decision this way or that way. We did a transplant at 2 o'clock in the night. Press did not know about it for 3 days. Patient had a urinary leak, we reimplanted. Patient lived for 12 years. And that is the story of transplantation at Sanjay Gandhi. Now, I would like to act as a devil's advocate and ask the AIMS Bhopal team at why do you want to start a transplant program? This question needs to be answered collectively and individually. Because I don't see transplant, I would agree with you have one of the best teams I can think of, and I'm fortunate to work with all the panelists you named at some point in time in my career, and I know their capabilities. And they would agree with me. It is much easier to remove and stick a kidney, but it takes hell out of a transplant team to keep them surviving for a very long period of time. Most of the times, our decisions are insinuated because others are doing it. But I would like you to take a pause. In this crowded world of competition, where do you expect AIMS Bhopal would be a singular story? And that's why this question is very important to answer. Why do you want to do a transplant? It's a team. And you know that team is not only my story has clarified, it is not the team I'm talking of urology, nephrology. Everything has to be in perfect alignment, including the administration. And I'm very happy that here Dr. Singh is leading from front the program. The story of team is that every team member has a different rainbow colors. They come with their aspirations and they would like to be submerged. And a program like transplant, which puts the team to very high profile, usually transplant surgeon dominates the scene. But it is the responsibility of the transplant surgeon to make sure that all team members' aspirations live. And you look at how a team is weaved, everybody has an identity and everybody has something in for them. If you want it to be put your money on long-term horse, or then probably focus on building a team, a socially strong team, which is technically competent to achieve common aspirations. Now, team means always, again, my subject is leadership and management of late, so I would divert a little, but it is relevant to the subject that usually team means we share an orange and divide it into the things, but that is one of the ways you should never do it. What you should do is that try and see this peel. Orange, everybody's focused on the basic orange and nobody's looking at the peel of the orange. As you look and know your team, be people who are interested in the peel of the orange. Take away that focus and make sure that everybody has something to. And you would be amazed to know orange peel has 40 ways to use an orange peel. So don't think and in orange. And same thing is about the transplant program. I don't know. I read somewhere it takes about 50 to 60 people to make a transplant program, a patient transplant patient walk out, minimum 50 to 60 patients. Whole lot of people are involved in the transplant program and you can't treat them as lampposts. If you really want aims to Bhopal to have one of the leading transplant programs, not only in Bhopal, but in the whole country to find its rightful place. Please think in terms of building a very strong team, not leaving one outside it. Whenever we talk of such exciting subjects as introducing something new, we usually focus at our strengths. Nobody minds, looks at the rat or something, which is your weakness. And I'm sure you should first look for your weakness because these weaknesses, if you can turn them into strengths over a period of time, you would have a very solid beginning. So again, trying to say, don't keep your focus on first transplant and your excitement limited to the first drop of urine you see after the clamps are released or the patient walking out, but think big, think in chain, think big, keep your feet on the ground, and all big things would begin with the first step. So do take first step. Don't be pessimistic about it, but think big. Your plan should be your own plan, which should not align with your panelists or something. They have achieved great things in their life in different directions. Now, what is big plan? Part of my story is that for 1 year, our program was great. Exactly 12 calendar months. Anish will join later. He is one who is witness to it because he was our first resident, not only in urology at Sanjay Gandhi, but first resident ever recruited by Sanjay Gandhi Postgraduate Institute. So 20 transplants were done in first year, and all 20, 100% patient and graft survival, including one cadaver, which I told you the story. And I was gloating all over the country, carrying those slides of 100% patient and graft survival. Egos are flattened in due course of time. When I came back after a lecture from Hyderabad, and we had 7 transplant listed. Believe me, all 7 acute rejections on table. We lost all the 7 kidneys. And there was a wave of depression at that point in time. We didn't have a reputation to spend on. And then I believe our transplant team worked hard, read every bit of literature on why did it happen. And then we found that there could be anti-endothelial antibodies. At that time, Kaufman and team in England were working on anti-endothelial bodies because their program also faced a similar fate. And I was traveling to US, so I stopped in London, talked to Cameron, spent a day in their lab, but we could not establish the anti-endothelial antibody testing. This is outside HLA system. And to our surprise, then we said, Vijay Kher said that we are having patients, and now I think my car mechanic could not find a thing, so he ripped open the engine and reassembled, and everything worked well. So we started doing the transplant, and then there was no stopping. As of now, I believe the center is the premier center, the only government institution, and I'm really proud of the people who carried this there, and they have done close to 4,000 transplants by now. So what I'm trying to tell you, at that point in time, I attended an international meeting, and I saw one case being presented from Great Ormond Street of a infant who had, of a fetus who had bilateral multicystic disease, and urologists would know that is incompatible with life. And this case report was that they kept, did the in utero manipulation, they make the baby to deliver prematurely, started a neonatal dialysis program on that baby, and they showed that girl dancing with mother's kidney at the age of 11. Now imagine the quality, what is the target there? Immediately, God was great, and I came back, and in 97, I took over as director, and this case report was in my mind. And I said, I don't want this institution to be yet another institute doing kidney transplant. And I said, I want it to be a neonatal and infantile or pediatric kidney transplant program. We trained 2 pediatric nephrologists. Later on, this is a story. But what I'm trying to say, that the challenge is not in the numbers. If you really believe that if you can keep a 15 kilogram kidney child, Sanjay would really tell you that it would need 124 hours would be less for a nephrologist. And my pediatric urologist came and said, we have no work in pediatric nephrology. It was my failure as a leader not to translate my perception of what is the quality of work. I can tell you, in India, we have great people, but what we lack is accepting challenges, creating challenges, and doing something which nobody is able to do. The last part is that collaboration, and very recently, Pranjal was a part of this rainbow collaboration where we, myself and Dr. Menon, had established the robotic renal transplant. And here I want to use this example that what I learned from Menon about creating a team. And he used to ask me, because what's the thing? I said, only 2 things bother. When I left active transplant program, I had a patient who had wound infection, and we managed him for 6 months and ultimately lost the kidney. In those days, we'll meddle with immunosuppression and all things like that. And then another was symptomatic lymphocytes. So I see these two problems. Otherwise, kidney transplant is pretty standard procedure and it hasn't changed much. So he said, no, let's do it. And then we started looking for the team, and he looked at everybody possible who has any experience in this coalition. When we developed robotic program, we consulted Inderbir Gill, who is one of the doyens of laparoscopic and robotic surgery. We got around Jill Natty, who had done 50 cases in obese people. We went to Ohio State to use the cadaver facility with Bob Benson. We had Ravi Barot from England, who was working as a fellow, and we had Wuju from Korea. And then we had great Indian collaboration with Rajesh Elawat and Pranjal Modi to do this. Now, very recently, last paper we have published in Journal of Urology, about to appear. And these 2 points, it is a non-inferior trial as far as the graft survival and rejection-free survival is concerned, or other factors are concerned. Only 3 things which are significant. One of them is the lymphocytes, symptomatic lymphocytes were 0. Wound infection obviously were expected to be 0. And the pain, it has a benefit. And now the last slide I want to tell you that director mentioned in his August address about the constraints, and I've been knowing about the constraints are bound to take place. But according to me, constraints are the best way to innovate. No lab has survived with affluence. And that's why I would say that's where you apply your mind to find easy solutions. India is a place for jugaad. Similarly, don't be depressed by constraints, but do everything right. And the last thing I would like to say, what bothered me in Indian environment when I compare to US environment or even CMC Vellore experiences, that we have far more buildings than activity and functions. And CMC Vellore came up with the first kidney transplant program. I was fortunate to be part of the first team in 70s with Dr. Mohan Rao. When I joined, he had done 27 transplants, and I had seen it was a very dingy thing, no dedicated theater for transplant. 11 o'clock, cardiac people, Stanley John would finish the list, and we'll get 4 hours to do that, cleaning the theater, and then we'll do transplant there, one transplant room. So please focus on functional superiority rather than infrastructure, or putting a board that AIM Bhopal Kidney Transplant Center or Transplant Center. That will anyway follow. But look at from the point of view of patient, that is this patient being managed as it would have been managed with Sandeep Guleria or somebody who has really pioneered or established his kind of thing. So with this, I thank you and offer you my unconditional support for whatever we can do. But I must compliment you, the kind of people you have to support you, or the panelists. I'm looking forward to hear to them, are the best in the country. And I have no doubt that one day I'll visit you when you would be busy doing kidney transplants and managing them. Thank you very much for this invitation.
Thank you very much, sir.
I really appreciate your support and unconditional support. So this is a great thing, and I really thank you very much for that. Yeah. And I hope that Dr. Manoj and Ketan and others, they will take clue from this, and I think they will continue dialogue with him. Yeah. Continue, please. Yeah.
Thank you, sir. Sir, over to chairing team.
Thank you so much, sir. Dr. Dorairajan, can you say something? Dr. Dorairajan? Sir is there?
Yes, sir is there.
Yeah.
Dr. Dorairajan, sir.
His mic may be on mute.
Sir, it's unmute only, sir. Okay, fine. Uh, Anit, madam. Okay, fine. So, so I would like to welcome our next honorable speaker, Professor Dr. Sandeep Guleria, sir. Anit, ma'am.
Yeah, I was just happy to hear Sir speak so well and put forward his thoughts on how we should work ahead with the team. And he put a lot of thoughts in the mind, and I like the way he put forward how it started with the cadaver, the first transplant. And I can see the teamwork, how he exemplified it. Thank you so much.
Sir Durayajan, sir. Can you hear me, sir? Okay, so I will welcome next honorable speaker, Dr. Sandeep Guleria, sir. Sir,
Thank you.
over to you, sir.
Thank you. Well, it's been a privilege. Can I just thank Manoj and all of you for having called me for this meeting. It's such a pleasure and a privilege to be here. It was absolutely wonderful to listen to Dr. Bhandari and, of course, to meet Dr. Sarman Singh after so long. I've been a little bit busy in practice and haven't had time to catch up with my colleagues. But before I begin, I think it's very important for all of us to understand, and I'm given a very non-surgical topic, that ethics is a very unusual topic. It's a personal topic, it's subjective, it's your own person's perception of morality, and it's a reflection of your philosophy of life. Ethics grows with experience, it's nourished by your years of collective contribution. And remember, it's just not laws and legislation, as Dr. Bhandari said. And surgeons have a unique position because they're operating. The individual will surrender to them. It's an irreversible operation they can do. And sometimes they can kill an individual. The fundamental principles of ethics, which is important for you to remember, is the respect for autonomy, benefit, that we are here to help somebody. We are here to cause no harm. There must be free and informed consent. There must be justice, and we must respect the dignity, integrity, and equality of human beings, fairness, and keep the common good at our heart. Right. So the background is like this. Remember, transplantation represents a very notable advance in medical science. But it also represents, and this is very important, great ethical, legal, social, and medical problems of acute complexity. And what may seem right to you today may not seem right to somebody else in some other part of the world. And remember, for ethics, only some values are held universally. There is no universal ethical system. It's important to remember that values that are brought to bear on transplant issues are usually determined by cultures. 3 words and 3 definitions that you must understand when we talk about ethics. The first is altruism. Altruism is very clear. Somebody who gives an organ or anything out of against personal preferences for somebody's well-being. So he wants to help somebody, he may not know that person, and that's altruistic. The other is deontology, which is basically stresses that individuals have to have a regard for individual dignity and respect for each other. And the third is utilitarianism, which means the greatest good for the maximum number. What is good for everybody? So when we talk about ethics in transplantation, the first ethical thing is that a live donor transplant involves a donor. And this could be related or unrelated. And it becomes important when we talk about this to remember the concept of autonomy. The Greeks said that autonomy is self-rule, which means a person who comes up to give a kidney should have the liberty and be independent and understand what he's going to go through. The desire to give an organ should be intentional. It is our duty to ensure there is no coercion. He should understand and be well informed, and there should be no controlling influences.
छोटा वाला ड्रम है? हाँ?
I think it's important to respect patients as individuals and honor their preference in medical care. We must remember the physician is duty bound to acknowledge patient's autonomy, and nowhere more is this more important than transplantation. We must remember he's not a case, he's not a, somebody who's come to this private ward, but he's a fellow human being. And we must give him the liberty to choose. He must be made aware of all the options. A man may have renal failure. Now you have this very commonly. He's just not willing to take a kidney from his wife. There are personal preferences. There are personal differences from his daughter. So it's our duty just to tell him of the options that are available. The decision that he takes is his own. We may not agree with it, but we must abide by it. And therefore, we must acknowledge the right of a patient or a donor to hold views, to make choices based on personal values and beliefs, and disrespecting this and ignoring, involves an attitude that ignores, insults, or demeans others. And this also denies independence. The other thing that we must understand is the fiduciary, which is the duty to act in the patient's best interest. And this basically is the legal relationship between two or more parties, most commonly a trustee and a principal or a beneficiary. So this is a live donor. This is one of our first transplants we did way back in '94. This is a father giving to a son. And if you want to know how much you must assess your donor, I would advise you to look at the KDIGO clinical practice guidelines. I was privileged to be associated with this group of 10 people. We published this last year in Transplantation. And it just tells you that you must have in every hospital a donor's advocate, somebody who looks at the donor separately from the transplant nephrologist or the transplant surgeon, spends a considerable amount of time talking to him, and advocates and makes sure that his best interests are safeguarded. For example, it's quite common that you might come up across this in transplantation. A 65-year-old male has renal failure. His blood group is O, and his daughter who comes up has a blood group AB. You know now that he is not her biological father. So it's a huge problem, because to prove the relationship, you have to do an HLA. And the HLA is not going to match with this blood group. Should you tell him? Should you proceed? How do you get across this? So these are clearly ethical problems that will come up in transplantation. The other thing is using the spouse as a donor. And nobody is very sure whether this is a social necessity, a compulsion, or is the wife being forced by the in-laws to give a kidney. We looked at this and we assessed the influence of kidney donation on the quality of life and anxiety and depression on life-related donors. We noticed all our donors some were illiterate, some were primary school educated, some went to college. We did a WHO quality of life questionnaire, which is basically looks at how you view yourself in life. It looks at you in 4 domains: the physical, psychological, social, and environmental. We did a statistical analysis, and we then, of course, published this in the Indian Journal of Urology. But what we showed was that irrespective of how educated you were, what your relationship was, whether you were a wife, husband, son, father, whatever your relationship was, the quality of life of a donor after he gave a kidney to somebody he loved increased after giving a kidney. So his quality of life improved. Most people thought this was the best thing they ever did in their lives. We then split this up further, and we looked at the quality of life of female donors who came up to give a kidney. We published this in 2010 in the National Medical Journal, and we found again that females, when they give a kidney to somebody they love, have the best quality of life as compared to anybody else, which means all donors have an improvement in quality of life, but the mother and the spouse have the largest improvement. And we were unable to explain this and just concluded that it was maybe because females were brought up in an atmosphere of giving and were used to giving. So what we concluded was there was significant improvement in the quality of life of donors. This is more profound in mothers, followed by the wife. And of course, the quality of life is poor when the recipient loses his graft or he dies. The other issue that will come up in any transplant program is organ trade. And this is an issue that has been ranting the transplant society and all of us who are in transplants, whether in the government sector or the private sector, for years. It's an ethical challenge of exchanging human kidneys for money. Donors have the biggest dilemma and stir the biggest debate. There is a human angle as well. You know, if you have been following up a patient for 20 years and she develops renal failure and she has no donor in the family, and she comes and asks you, can I fly to this country and get a transplant? Can I go to Sri Lanka or go to Turkey? And well, you know, you'll have to think about it. But I think most of us would say, well, you know, I think it's a good idea, because what do you do? I know I can't help you because it's not possible for us to do an unrelated transplant. So this is a fairly gray area yet. And I don't think the last word has been spoken. It's a huge ethical debate. Poverty is the greatest force for exploitation. And it is good to relieve, some people would say, even a small part of that poverty. Ethically, claiming that a poor man is incompetent to make good decisions is really sheer paternalism. This is nothing short than ethical imperialism. And therefore, there is some truth when people say that maybe you should look at controlled selling. But all this is highly debatable. So when we look at paid organ donation, lots of us will feel revolted. And we must remember that countries where kidney vending would flourish are those where ethical regulations of the practice are likely to become more corrupt, because it's easy money. So many people get involved, touts get in, touts get out, doctors get involved, everybody's a party to it, and the only paying person is the recipient. Professionals should cherish the concept that all persons and their non-renewable viable organs should be cherished as above monetary value. So we did have the Act in 1994. We know that it recognized that a number of patients would not have live-related donors. It said you could get a good friend, but knowing the current scenario, it's fairly difficult. Anyway, the Americans came down to Chennai to study live undated donation and published a paper by a gentleman called Amit Goyal in 2002. And what he found was that among paid donation in India, selling a kidney does not lead to a long-term economic benefit. Clinics and middlemen promised on an average 1/3 more than was actually paid. And what they said, that physicians and policymakers should re-examine the value of using financial incentives to increase the supply of organs for transplantation. And although patients with kidney failure, there is no doubt if you're looking after them, do need a transplant, they felt that such treatment should not be based upon exploitation of the poor. There is, of course, the Iranian model, and you'll be surprised to know Iran today currently has no waiting list for organ transplants. So anybody can go up as a donor. Having said that, Shiraz has an extremely vibrant cadaver program. So they've done well on both. They have a regulated paid organ market. They have an excellent cadaver program at the Shiraz Institute. And I've had the privilege to see them. And I think it's a very well-run program. But their selling is highly regulated and does lead to a number of questions being asked. For example, we must know that there is excellent quality of life of donors who give a kidney to somebody who they love in the US, in India, Canada, even in Norway, where the initial studies came from. But 90% of live donors, like I said, would think it's the best thing they did in their life. Unlike paid donors, 80% would not do the same thing again. So I think the last word is not yet said. A continued debate, rather than accepting that the argument is over, is clearly indicated. So we can all evolve to give our patients with end organ damage the best quality of healthcare in our existing circumstances. The other issue that ethicists really usually raise is about cadaveric organ donation. And if you go now into literature, you'll find lots of reports about people who are brain dead, who are waking up. I shouldn't be saying this, but some authors assert that there needs to be a more rigorous criteria for defining the brain death. And definition of cerebral cortex alone is not acceptable. I was in England, we were using anencephalic donor infants as donors, and currently people feel it's unethical because they do have brain life. And again, hugely ethical issues that we will need to sort out when we carry on a transplant program. For example, you may have a 15-year-old male who is brain dead. The family refuses to accept the concept of brain death, saying his heart is beating and he is warm. And they'll show you so many things in article, even as recent as this year, where somebody after brain death has woken up. And then they decide that when they want to donate the organs, they want to give it to someone they know. And they will talk about non-heart beating donation as well. So it's important for you to decide where the ethics are going to lie in your program. So non-heart beating donors are patients who are bought dead, who die after failed resuscitation, who arrest in the casualty. And though their results are not as good, they're almost comparable if it's a controlled brain death that happens. And of course, the important question, who owns a body after a patient dies, after he's brain dead or he's non-heart beating dead? Is it the state? Is it his next of kin? Can the patient decide when he's dead whether he's going to opt in or opt out? Can we give incentives to the donor families or not? And can we give incentives to the physician? And therefore, donor incentive, which is currently being practiced in large parts of the world, some believe that patients could be persuaded to donate organs if we said we'd pay your funeral expenses, postmortem, educational expenses of bereaved children may also be offered. And some would say even direct cash payments can be made. And therefore, this is a huge area where ethics will come into play. What about cadaveric organ allocation? Does the donor have a say or not? Does the physician have a role? Is it a random choice? How do you decide who to give a cadaver organ? Is it going to be decided by the ability to pay of the patient, his social worth? Or are you going to transplant somebody like Steve Jobs so that your program gets a lot of publicity? Or are you going to use the media so you get a big man to transplant? And therefore, this is it. You have a 23-year-old brain dead donor donates his organs. Who do you decide who do you give it to? Would you give it to somebody who has HIV? Would you give it to somebody who's a criminal? Would you give it to a colleague? Would you give it to a young girl who's awaiting a transplant, like this photograph, who's only 6 years old? And this girl now goes to college. Or this lady who's 66 years old who got a transplant when she was 66 from a cadaver organ. So who decides how organs are to be allotted? And how can one take this decision? And is the HLA system really relevant today for organ allocation? And therefore, the most of justice versus utility, the most appropriate offering organ showing maximum benefit. That is the greatest good to the greatest number. The utilitarian people would argue each organ should be transplanted into a recipient in whom it will survive the longest. And justice requires that a fair opportunity for everyone in need of an organ transplant. For all of us who are involved in organ transplantation, I think it's important for us to find a compromise between both these potentially conflicting ethical principles and be aware of the problems caused by each principle. Remember, the ability to pay can be a major issue in a developing country. Transplantation is easy for the rich, but majority of the patients I saw during my formative years could not afford a transplant. And remember the saying, what we used to say, a transplant makes a family poorer. So the family often becomes poorer, and the prognosis, we said, used to be decided by the size of your wallet. So this is finally the summary of the Declaration of Istanbul, which basically said that screening, prevention, treatment of organ failure programs, which means we must pick up people who have diabetes, hypertension early, should be implemented by local governments. Recovery from organs from deceased and living organs should be legislated by local governments according to international standards. The allocation should be equitable and fair. There should be long-term and short-term care for people who come up to give their organ. And organ trafficking, transplant tourism, and commercialism should not be allowed. With this, I'd like to thank all of you. It's such a privilege to be here. And I think we must remember that in ethics, nothing endures but change. Thank you for the opportunity.
Thank you, sir.
Wonderful. Excellent, Dr. Guleria. Thank you very much.
Thank you, sir. How do I?
Sir, the chairing team, Duriran sir,
Yeah.
are you
Am I
hearing me, sir?
audible?
Yes,
Am I
sir. Yes,
audible?
sir. Yes, sir. You are.
Yeah. So it's been a privilege to be part of this program with two very important persons, Professor Bhandari, who founded the department at JIPMER, and Professor Guleria, who was my first mentor and teacher in kidney transplant. I'll just check, even though Dr. Guleria has just spoken, there are three things that I could flag as important takeaways. One is the donor autonomy. In the beginning of our transplant program, we may be tempted to kind of persuade a patient to undergo kidney transplant, but we need to be careful that we resist this temptation and be objective. And similarly, we should be donors advocates. Sometimes we may find a donor who is not the appropriate or is unwilling. Again, we should restrain ourselves from coaxing that patient, and we need special precautions that we don't be sure that spouses, especially the women, are not exploited as potential donors, because one slip, especially in the beginning of a transplant program, can really set things back by several years. So these are key takeaways that I would flag. Professor Bhandari also mentioned certain very important takeaways. For a successful program to be launched, top management should be the driving force. The director and the medical superintendent should be ready to overcome all obstacles. Because transplant is truly not a nephrology, urology affair, but a teamwork which includes anesthetists, nurses, critical care physicians, biochemistry, pathology, blood bank, immunologists, and pharmacologists for blood level, drug levels, and so on. So team building and top leadership are key ingredients in starting a great transplant program. Thank you.
Thank you, sir. Thank you very much, sir. So, sir, I would like to invite our next chairpersons, Dr. Mahendra Atlani, who is a nephrologist, assistant professor in nephrology at AIMS Bhopal. Then Dr. Santosh Agarwal, consultant urologist at Bansal Hospital, Bhopal. And Dr. Sunina Tejpal Karn ma'am. She is associate professor in the Department of Anesthesiology, AIMS Bhopal, and trained in transplant anesthesiology at SGPGI, and then worked at ILBS. So I would like the chairing team to welcome our next speakers.
Good evening, everyone. It is really we are privileged to hear them talk, and at present it is my privilege to invite Dr. Shantila's meeting, a person who are excellence and a pioneer in the field of laparoscopic kidney transplantation and robotic kidney transplantation section. Talk or techniques and modalities.
Hello, sir. Hello.
So you need to mute yourself.
Am I audible now?
Yes, sir. Yes, sir. You're audible now, sir.
At the outset, I would like to thank Professor Dr. Sarman Singh and the entire team of the Bhopal AIMS. It's a proud privilege to be with the team in this webinar. The topic allotted to me is technique and novelties in renal transplant. It's purely a surgical subject, but as in his inaugural lecture, Professor Sarman Singh said that we would like to start the program in several things other than the technical aspect would like to know. So I think the first two speakers have already elaborated how they have started the program and ethical dilemmas. What is most important thing is that I will talk about the experience at IKDRC. We get a tremendous government support. Without government support and without autonomy of the transplant program, it is very difficult to develop this program. huge amount of manpower, efforts, and finance is required to establish and grow this particular program. The government of Gujarat, this is the only public sector hospital in the entire state which gives the services of the transplantation, and we do about 350 to 400 kidney transplant a year, which includes 80% of a deceased donor, living donor kidney transplantation and 20% of deceased donor transplantation. Our experience is over 900 deceased donor kidney transplantation and about 5,600 living donor kidney transplantation. So it's a very huge experience this institution is having, and I was fortunate enough to join this institution from 1995 onward. There are governments, for the pediatric program, there is a special school health scheme by the state government, and there is an unlimited grant available for development of the pediatric transplant program at IKDRC. Also, for all the patients who are having a BPL card, they are treated free. There is a Yojana named Ma Yojana, Mukhyamantri Amrutam Yojana, which includes also not only the free of charge transplant, but also it includes the robotic kidney transplant free, pediatric transplant, as well as adult patient transplant free of charge. So there is a lot of support even for the deceased donor transplant. The management of the donor, if you have to do, approximately 50,000 rupees are paid by the government through the SOTO, Gujarat, and to maintain the deceased donor. And even if it is a private hospital where we are managing the deceased donor, it is very important that everything is controlled by the government, but then they are paying for the care of the donor, irrespective of which hospital is going to use those organs. So I think a very broad view is required to establish the transplant program, especially the cadaver transplant program and also the living donor transplant program. Majority of the people, the center in India, they have started with the living donor program, including ours also. And I think the AIIMS Bhopal also may start with the living donor program. Now coming to the next slide. Coming to the technical aspect of transplant, as already Professor Bhandari has mentioned, it is a teamwork. And there is extraordinary skilled 2 surgeons are required who can do the donor. One team can do the donor operation, the other team can do the recipient operation. There are 3 important aspects of donor operation. One is open donor nephrectomy. Since several years, I think since 2005 onward, it's very rarely used in my institution, and it is almost obsoleted. However, it is still the operation of choice in some of the institutions and some of the transplant centers. How the donor flank incision and transplantation, or maybe the mini incision nephrectomy is popularized at several centers, but at our center, it is almost the laparoscopic or retroperitoneoscopic donor nephrectomy carried out. So the surgeon who is very well accustomed with that particular type of operation, either laparoscopic or open operation, should choose the operation which he knows about it. There should not be an unnecessary experiment, especially to start with. Robotic assisted laparoscopic surgery also can be done, but it is limited to a very few centers, and it is used in current practice, and it may be the future. As far as the recipient operation is concerned, it is always by and large the open operation, and it is the current practice and gold standard. However, I have established the laparoscopic kidney transplant program in India, and then we have seen that it is easily translated. We have translated to the robotic assisted laparoscopic surgery, so which is the current practice in my center, and laparoscopic kidney transplantation is almost obsoleted. Even though I have established it, I have to quit it as the time passes because the development of the technique and science has grown. So what is not included in my talk is technique of procurement of deceased donor organs and the details of the band surgery, and also about the perfusion fluid, which are usually the part and parcel of the technical aspect of transplant. I'll go with how we do the donor nephrectomy, and it's a small video of 3 minutes. We can put a kidney position and a small incision into the flank with the tip or close to the tip of the 12th rib. And you can see the retroperitoneum is accessed. A space has been created. And a balloon, it's a disposable balloon, cheapest disposable balloon, which costs around 50 rupees. Every urological armamentarium is having a 2 mm syringe to take out the clot from the bladder. So this has been used to inflate the balloon, and you use the sterile saline. We minimize the wound size so that the gas does not leak. And after about 500 ml of the inflation, we take out the balloon. We put under vision, we put the trocar. We all know the laparoscopic surgery is an advantage as it gives only the 6 or 7 centimeter incision to procure the kidney, and compared to the open operation, which gives a lot of pain to the person who is otherwise normal individual and is a donor. So this is the initial inspection. You can see the psoas muscle. Just keep on. This is the kidney covered by the gerotas fascia, and you can see it's a nice, beautifully created space in the retroperitoneum without much hemorrhage. So under the laparoscopic view, here you can see picture in picture that a second port is introduced inside, and there is another port introduced from the back aspect. So only 3 ports are required for retroperitoneoscopic surgery, and you can reduce the size of the port. We even today, after doing more than 2,500 donor nephrectomy, we use the reusable autoclavable instruments. I'm working in a public sector hospital. You can see just with the minimum dissection, inferior vena cava, ureter, everything is very clear. And I do not use a lot of cautery or other fancy instruments. You can use this beautifully. We have a ligature. You can see the iliac artery. The ureter crosses at that level of the iliac artery. There you are going to clip it in future. The gonadal vein, the ureter, you can dissect out bluntly or sharply as the need arise. So a team member, which includes here the assistant surgeon, who is a camera person. And I think that is very important, that one camera person should remain from very beginning till the procedure is established. Because every time if you have a residents changing or the camera person changing, the vision, they may not understand the retroperitoneoscopic surgery or a laparoscopic surgery, and then there is a problem. So the result may not be available. You can see the artery is likely to go in spasm. So unlike in a simple nephrectomy, the surgeon should not dissect too much of the artery, right? Here we can see some tissue is left behind on the artery, and this is just a ureter. Entire ureter is dissected, vena cava is dissected, artery is dissected. Here also renal vein dissected, and you can see the entire length. So coming to the left side, that was the dissection on the right side. The similar anatomy you can see from behind. If you are doing open operation, this is the anatomy very familiar to you. If you are doing transperitoneal, it is exactly reverse than this. So here you can see the arterial dissection. You can see the left renal vein. Typically, we take the left kidney because it's having a longer length. I think there is some problem with the slide. Just a minute. Yeah, okay. So now clipping the vessel is very important. This is just behind the IVC. Typically we use the Hemlock clip. You should be having availability of the stapler also. For the vena cava, right vein control, we always put endo-TA stapler. So when you do the donor nephrectomy, the armamentarium should be available. It cannot be worked only with the clips sometime, especially the metallic clip, which can dislodge, and then there could be a torrential hemorrhage. In donor, nobody can accept the hemorrhage or nobody can accept the complication, because by definition, donor is a normal individual. So it's very important to have all armamentarium available. Once kidney is out, like in this case, there are 3 arteries. So don't hesitate in taking out the multiple arteries, but you have to have experience before that. So initial case selection should only be with the single artery and single vein. Then after you can go with the multiple arteries, like 2 arteries or 3 arteries. And you have to take out the kidney, perfuse it very well, and then on the bench, as far as possible, always anastomose on the bench. If you leave behind it and try to do the multiple anastomosis on the recipient side, you are likely to increase the warm ischemia time. So in this case, like the two arteries are communicated together, anastomos together, and you can see now the third artery, which is enough, long enough, and then also mean anastomos here, and then you can see like the fish mouth appearance of the artery. And you can see here very nicely a transplanted artery here with the external iliac artery. We choose usually to the external iliac artery, very rarely now we do the internal iliac artery anastomosis. Reason is, right, it is very simple and it is reduplicable even at the level of residents or junior consultants. Now, sometime if you have a cadaver, you have a marginal kidney, the same dissection, external iliac artery, external iliac artery is somewhere to the right of the photograph. What we have shown is the common iliac artery and common iliac vein. The anastomosis is carried out, keeping first is venous anastomosis, followed by arterial anastomosis. And you can see here, like vein is with the external iliac vein, then the artery is with the external iliac artery here. This is the inferior graft. And this is the superior graft where you can do the anastomosis with the common iliac vein, which is lateral to the common iliac artery, and the arterial anastomosis is not visualized. You also can have a two separate uretary implant into the bladder, typically by Lee-Greger technique. And these are the two ureters slinged by the tape. Coming to the robot-assisted renal transplant, because the subject is also the advancement in a transplant, in collaboration with the Vetikuti Foundation and the Medanta Institute, Professor Bhandari has already mentioned about it, Dr. Manan, Dr. Bhandari, and many other people. We were one of the pioneers in establishing the transplant program robotically. The robot is a very important armamentarium, and at this point of time at my institution, the robotic kidney transplant is, the cost is bad, partly by the government and partly by the patient, especially those who are having a no BPL card or those who are not in a pediatric school health scheme. Here, like the robot is docked between the two legs of the patient, and you can see one assistant port. Initially, we used to put an assistant port here, but now it has been placed here, one single assistant port only instead of two, and forearm robot is docked. What you can see is a very limited external iliac artery dissection and beautiful vision of a lymphatics also. One of the common complications of a transplant, if you bear the artery very long, is a lymphocele occur in a post-transplant phase. So that is to be kept in mind, and you can see the vein. The vein is typically situated inferior-medially to the artery. The complete mobilization vein should allow you to lift up the vein like this, and that means you have adequate mobilization of the vein. You cannot mobilize the artery like this because it produces the problem of a lymphocele. You can see this is the flap raised and a very small incision, 7 centimeter phalangeal incision. Both the recti are separated out in between, so there is no muscle cutting at all. And this is the kidney. Band surgery is done, two arteries anastomos together. It's a single layer jacket of the single layer gauze piece is made for the jacket. And this is the artery. You can see kidneys drop through this incision and the wound is closed very promptly. Robot is redocked and you can see the robotic instrument. This is the pot scissors. You just open the external iliac vein. Application of bulldog, they are very special bulldog. We use Canlan bulldog, so that is around 350 gram bulldog, which occludes artery as well as the vein both. And this is a Gore-Tex suture which is used, and anastomosis has been carried out. Once the venous anastomosis is carried out, a bulldog is applied on the renal vein, and we allow the circulation of the vein to happen. The extra lower limb circulation is restored. Venous drainage has been established. This is followed by application of same bulldog, which are removed from the vein. They are applied on the artery, and arteriotomy is placed. There is it's not only the small incision, you really have to cut down the wall of the artery to make or you use the aortic punch if you are doing the open operation. It's difficult to use the aortic punch in a robotic surgery. Dr. Rajesh Allawat is using it. You wash out with the heparin saline because there are always clot in the artery, and that clot has to be taken out. This operation is very important because this mimic all the steps of the open transplantation. So in open transplant, you have a heparin cannula. Here you don't have heparin cannula long enough so that you can put it from the anterior abdominal wall. So we use the ureteric catheter, which is always available in all urological armamentarium. Equal distribution, very nicely done suturing of the artery. And then just you open the clamps, beautiful perfusion of the kidney, and then you can see the venous drainage. confirm that there is no leak, lymphatics are preserved here, and you shift this kidney on the retroperitoneum side and do the, then after we go with the implantation, classical Lick-Greger method implantation, which has been described, and I think all urologists are very well versed with these things, and we carried out. This is the first layer, means mucosa to the mucosa anastomosis, and then this is vitreosorography, which has been carried out. And finally, the retroperitonealized the kidney, we just put several clips, and which is helpful in taking later on the renal biopsy as and when it is required, and it also reduces the torsion complication. This is very important. Recently, we published the article along with robotic assisted dual kidney transplantation with monolateral iliac vessel. So what you can do by the open transplant, we can do all robotically the dual kidney transplant also. And you see the final result of dual kidney transplant is single incision, anastomose first kidney with the external, common iliac vessels, then perfused it, allow it the urine to produce there, open the incision again, or maybe you can use the gel point or the Alexis retractor, put the second kidney in and do the distal anastomosis, perfuse it, and then just implant it. So through the single, port side, you can put a two transplant together. We have education system in our institution. It's very important to start the education program in transplant because it is a long-term application of transplant. It's not possible that only few surgeons carry out the transplant. We need to have dissemination of the so many surgeons. So fellowship in abdominal organ transplant is a separate fellowship post general surgery, 3 years fellowship where somebody can learn the liver and kidney transplant and also some of the pancreas transplant in my institute. There's a fellowship in pediatric nephrology, which is also for 3 years, which is also after the, which can be done at the level of MD pediatrics, and somebody can do it 1 year of fellowship in Mumbai, which is after the DM in nephrology. Fellowship in pediatric urology and renal transplant, recently we have started, it's a 2 years fellowship. And also, of course, now we have MCH urology. Let me tell you again, Professor Bhandari has inspected our institute way back in 1991 and started the DNB program. Now we have become the university status, and this is an MCH program where we can train the kidney transplantation as a part of urology. In summary, advancement in technology related to the laparoscopic and retroperitoneoscopic surgery and robotic platform can be used safely for both donor and recipient operation for kidney transplantation. In our experience, retroperitoneoscopic living donor nephrectomy is used for over 2,500 cases, and it is done by residents and junior consultant in our institution. Our experience of over 550 robotic kidney transplantation has created a challenge to the current gold standard of open operation, and it increases the cost of transplant is directly proportional to the use of advanced technology. So the administrative part is very important how we want to take the program. In conclusion, renal transplantation is a teamwork, and adoption of technical advancement makes both donor and recipient operation more patient-friendly. Thank you very much.
Thank you very much, sir. Over to chairing team, sir.
Dr. Pranjal is Dr. Santosh Agrawal from Bansal Hospital, Bhopal.
Hello.
Hello.
Hello. Yes, I can listen to you.
Yeah. Since we are talking about the novelties of the kidney transplant, and rightly you are the pioneer in first in laparoscopic kidney transplant, then you moved over to robotic kidney transplant. And the other novelties, which I wanted to ask, what is your experience and thought about this vaginal extraction of the donor kidney and vaginal intrusion during the robotic transplant? Have you done it? Putting the kidney vaginally. But that's the next step in the novelty.
Yeah, we have already done it, and I think there is a first paper published by us way back in 2015. Why I did not include this particular because of the lack of time, but
yes,
vaginal insertion of we have done already 50 cases of and we are coming out with that paper in a very short time. Laparoscopically, we have already done, and I do not take out the kidney through the vagina because our main approach is extraperitoneal, and from there to take it out from vagina is very difficult.
Right.
But Dr. Kishore from Kochi, he is doing transperitoneally, and he is doing it fairly regularly. But we have done mainly in a recipient side, right? Recipient surgery, transvaginal insertion of kidney, and robotic kidney transplant. Thank you.
Thank you. It's good to know that the kidney now you are doing You had done 50 cases putting kidney vaginally. I think that must be a landmark paper when you publish it. Thank you, sir. Dr. Ketan, you can invite the next speaker.
Yes, sir, you can invite, but on your behalf if you want. So,
Yeah,
yeah.
please.
I would like to invite our next honorable speaker, Dr. S.K. Agarwal, sir, professor and head Department of Nephrology from AIMS, New Delhi. Sir. S.K. Agarwal, sir, Dr. S.K. Agarwal, sir. Am I audible to you, sir?
Yes. Able to listen me?
Yes, sir. Yes, sir.
Is my slide visible?
No, sir. Yes, sir. Now it is visible, sir.
Is now visible?
Yes, sir. It is now visible, sir.
Okay. At the outset, good evening to everybody and good morning to Professor Bhandari. It's a long time since I am able to see him and listen to him. I will also thank Professor Sarman Singh and the team from Bhopal. Before starting my talk, I will convey to Dr. Sarman Singh that probably it will be worth listening to. If you are recording this webinar, then worth listening to what Dr. Bhandari said in initial 10 minutes. And you should listen in between the line what he said. For a beginning
I noticed. Yeah, you are right. I noticed. Yeah.
For the beginning of a program, probably there are many things in those 10 minutes which are actually very crucial for a center who is starting a program. Expertise and advancement are probably for 5% of the patient. For 95% of the patient, it is more of a coordination and organization. And you being in the chair, transplant program should be institutional program. Somehow in many hospital, it has remained program of the surgery team or the nephrology team, which is not good for a center which is going to start the transplant.
Yes.
Coming to the my topic given to me, policy is a purposive course of action followed by the government in relation to the dealing with the issue of public concern. And there are three components in policy related to the health. First is policy formulation, other is policy implementation, and third is policy evaluation. Somehow we are very good in terms of making the policy, but not as good, if I say so, in implementation of policy as well as in evaluation, that how much policy has been implemented and in what way. If you see the number of renal transplant requirement in the country at any time, approximately 4 lakhs people of end stage disease needs a renal replacement therapy, which obviously renal transplant is the most important. But if we see the number of transplant done as of now is 2% of the need of the renal replacement therapy. Approximately 8,000 transplants were done in 2019. And in terms of a dialysis, peritoneal dialysis is again covered 2% of the patient, and 30 to 35% patient are actually maintained on hemodialysis. Although this number looks very large, 1.5 lakhs patient being on hemodialysis, but actually these are the number of patients who have been initiated. If you really go to little deep that how many of them are actually maintained lifelong on hemodialysis, this percentage probably will drop from 35% to 5% only, or maybe even lesser than that. Now coming to the donor source, which is the main topic of improving the living, increasing the living related and disease donor. There are two broad categories of donor, living and disease. Out of disease is donation after brain death or donation after cardiac death. And in a living related, as per the law, there is a group called near relation, which include the first, second, and third degree and spouse, and the whole group other than the near relation. Now, as you see the near related, I will only highlight where there is a scope of increasing the living related donor pool. There are nuclear family becoming more common, so the available number of potential living donor cannot be increased. So what we can increase is that in spite of many living donor being potentially medically fit and available, there is a need of awareness of long-term outcome of a living related donors, so that the existing potentially fit living related donor can be captured for donation in a transplant program. Now, second group of the living donor which are many years were not fit and were not taken is a sensitized recipient and the blood group incompatibility. Now, there are options like swab transplant, which is one of the option which for which is exploring other than non-related in a sensitized patient and in a blood group incompatible desensitization protocol and incompatible ABO transplant are being done, but the major issue is the result. Although result of ABO incompatible transplant has almost parallel to blood group compatible, but it increases the cost of therapy. And as we know, a large number of our patients cannot bear the cost of a compatible living related transplant. So the cost will be a constraint. Now, coming to other broad group other than near relation, it's a controversial thing. The only scope I see in which we can increase this is we can expand the scope of near relative, and one of the group which a large number of people agree is including in-laws in the definition of a near relative. So in a living related program, there are few scope of increasing the number. Now coming to the disease donor transplant, donor source are primarily two: road traffic accident and a cerebrovascular accident. And if we grossly include the approximate number, in a year, road traffic accident are approximately 1.5 to 1.7 lakhs death annually, and a stroke are approximately 5,000 per year. So this is a major chunk of potential disease donor which should be captured for increasing the disease donor pool. Now I will take you all through a potential diseased donor and road traffic accident, and you can imagine taking this example. And I will give example of, say, city of Delhi, but Dr. Sarman Singh and Bhopal team can very well visualize that if there is an accident 20 kilometers away from the AIIMS Bhopal. So first thing is that there should be policy of a resuscitation at the site, because a large number of accident patients die on the site. And if they die, they obviously cannot become the source of disease donation other than the donation after cardiac death, which is still in India is almost non-existing. Now, once the person is resuscitated at the site of accident, it needs to be transported to a trauma center conventionally. And we know what is the condition of and number of trauma center in the country. So we need to develop and make policy in terms of a trauma center. Now, once the potential donor reaches to the trauma center, he needs to be provided emergency care. Now, here comes the disparity of the number of beds in the country available and number of the potential trauma patient and number of the trauma center available in the country. Now, once he is managed in the, I am visualizing in our All India Institute, taking an example of a Connaught Place injury. So once he comes to the hospital, he has to be managed in an ICU setting. Now, where comes the number of, this is the number of death is one of the newspaper cutting last year. So once he reaches to the ICU, now then you can imagine how many ICUs in our country are trained for managing these patients in ICU. Now, while he is being managed in ICU, we need to we need to detect that who is the person in ICU can be a potential donor. And once we do that, there comes the maintenance of the donor, which in that category, a huge cost is involved. And there is a controversy that if the donor is maintained in one of the hospital, and after donation, if the organ goes to another hospital, who will pay the cost of the donor maintenance in the ICU? Now, once the donor is being maintained in the ICU and at the time of potential brain death, the diagnosis of brain death has to be made. Now, this is one of the major hurdles in brain death diagnosis, because the neurosurgery, neurophysician, and anesthetic and the other doctors who are the team for making the brain death diagnosis, their interest is the least out of all other teams involved in the organ transplantation. So there is a hesitancy in making the brain death diagnosis, and that is the reason that in the policy, more people other than the neurosurgeon and neurophysician has been involved, so as to increase the pool of people who can be involved in diagnosis of a brain death. Now, once the brain death has been diagnosed, the family consent comes into picture, and there comes the issue of awareness in the society. Now, you can imagine if the person dies in the ICU, and if we approach the family, and if they are listening the brain death diagnosis and a potential donation of brain death person for the first time, obviously we don't expect that there will be a positive response in majority of cases. So awareness in the society that yes, brain stem death is a diagnosis and the person is actually dead, and at that time donation is possible to save the life of many of the other patient of end organ failure. So here comes the awareness in the society. Now, after the family has given a consent, then there comes the huge setup of organization, because if there are 5 organs being taken out, there are 5 teams needs to be involved, both from the surgical side and from the medical side. All those needs to be organized, that who will retrieve the organ of a particular organ, who will retrieve kidney, who will retrieve. So all these things needs to be organized. And then here in organization also comes the allocation of the diseased organs, which itself is a major issue. Now, after the this setup of organizing whole of the organs and their team, then the question of procurement comes, and then only the recipient gets a organ. In terms of a organization, government has made a institution and a national organ transplant program. Although national organ transplant program was envisaged in 2007, it came into existence after a year or so. And from 2012, a body called NOTO, National Organ and Tissue Transplant Organization, which is expected to do the work of coordination and organization of the disease donor as well as the living donor program. Although NOTO contribution in a living donor program is very minimal, it's primarily for the disease donor program. And this is the central body. In relation to this, there are regional organization called ROTO, and there are 5 existing regional organization. And you've seen Dr. Pranjal Modi is one of the region in charge of the ROTO of that region. And under the region, in each state, there is a SOTO, which is a state level organization. And in whole this organizational structure, actually SOTO is the key body state level, because health is a state subject. So from that angle, organizational structure was made that the SOTO will do everything, and the ROTO will come into picture only once the organ is being distributed across the state. Then the ROTO will come into picture. Noto work is only a sort of a organization. In practice, Noto doesn't come into picture of the state functioning or the region level functioning. It's more of a administrative body and guiding. Although for NCR region, Noto act as a SOTO, so for Delhi and NCR region, it has major function of SOTO also to be performed. So as I said, SOTO is the key and the key body in whole of this organizational structure. You see, this is the number of death in 2019. All the UP tops 17,000, while Tamil Nadu, Maharashtra, Karnataka are much less. But still, the disease donor program in other state is much more, much better than the UP. What I want to say that it is the organizational structure which actually matter. In spite of having less number of the accident and death in many states, they are doing much better than the state where number of the accident related death are much more. So in brief, in summary, I will say that it's a government non-priority. Transplant is not a priority for the government. It is only after the illegal transplant came into light that the central government woken up, and renal failure and organ transplant came into some limelight. There is still lack of adequate infrastructure, as Professor Bhandari said, in whole of the UP, probably not more than 2 transplant centers are there. A very major issue is lack of good coordination, and I will again refer to what Dr. Bhandari said in those 10 minutes. Lack of awareness in the society comes at many stages, to which what I presented, taking example of this. Negative media publicity in country is also one of the issue which brings often halt to the active organ transplant going on. And obviously in all these things, finance is a major issue. Again, I will end my presentation to again highlight that it is coordination and cooperation of a huge number of departments, huge number of the people. I'm sure that the people in AIMS Bhopal who are currently present are fully competent to technically do the renal transplant and probably other organ transplant also. But it is probably head of the institution and other people in each department who are heading need to carry everybody along if they really want to succeed in establishing the organ transplant program, and which to start with will be probably renal transplant. With those words, I will thank you, Professor Sarman Singh, and whole team of AIMS Bhopal for giving me opportunity of sharing my views. And
Indeed, it is our privilege. Thank you very much indeed.
I will just take 1 or 2 minutes more. That it was privileged to be in Sanjay Gandhi PGI when Professor Bhandari was in the urology, and I still remember that we were having a room where we used to start, before starting the departmental activity, we used to have a cup of tea, and that thing, I mean, it's just example that these things matter so much in running the program like organ transplantation, which probably you will realize only once the transplant program is take off in your institute. Thank you very much again.
Yeah, thank you. Thank you indeed.
Thank you, sir. Thank you very much, sir. Over to chairpersons, Dr. Mahendra Atlani. Sir, are you there?
Oh, here, yeah, here.
Atlani, sir, can you hear me, sir?
Yes, I can hear you.
Yes, sir. Yes, sir. Yes, sir. Please.
Thank you very much, Dr. Sanjay Agarwal, sir. We were privileged to have you here for the second time. Last
Dr.
time,
Atlani, your voice, we can't hear you.
The quality of voice is not good, sir.
Yeah.
I'm saying we are privileged to have you here for the second time. Last time you guided us on the setting up the department and strategic. And thank you for enlightening us a few narratives and we whatever in the medical experience of India and giving so there we are left with only few options to increase in donor kidney transplant program. So probably, but you also believe that these new modalities are very costly and all these are
Couldn't hear anything. Atlani साहब, voice आपका बिल्कुल test नहीं किया आपने. Anyway, next person can Ketan, you can.
Yes, sir. Yes, sir. Yes, sir. Yes, sir. Sir.
I had one query
Yeah.
that regarding expanding the donor pool. Once we talk about diseased donor program in India, clarity regarding donation after cardiac death or circulatory arrest is not very clear. What is your take on donation after circulatory death in Indian scenario?
Dr. Sahab, I will frankly say that it's not my area. It's basically surgery team which get involved in terms of a donation after cardiac death. But from a scientific point of view, it's all right. But I will still suggest that to start with, don't think of a program of donation after cardiac death. Start from the simple thing, because initial success is so important in organ transplant that you have to really show that your first 5-10 transplant go as smooth as possible, and that will give a whole team moral really high. Then you step by step you go to the more complicated issues. I will only tell you that this donation of other than near relation is being done, and is a sizable number of transplant are out of donation other than near related. But I will give you example of Sanjay Gandhi. Sanjay Gandhi is doing so many transplants, but still they still do not accept a donation from other than near relation. So you can imagine the complexity of these things the moment you go beyond a living related transplant. As one of the speaker has pointed out, there are so many issues. So my suggestion will be to excel initially in the basic, uncomplicated, non-controversial organ transplant before going to other things.
Okay, Dr. Ketan, I am audible now?
Yes, yes, yes. You are very much audible, sir.
Dr. Sunena,
Yeah.
Dr. Ketan.
Yes, sir.
Just wanted to say something about this donation after cardiac death, which Dr. Sunena was talking. In my view, there is no proper legal framework in India to do a donation after cardiac death. PGI Chandigarh has done some work in donation after cardiac death. They have done few cases. Why I'm saying like this, because donation after cardiac death, there are two types of this donation. There's controlled death. In controlled death, you wean off the patient on off ventilator under a controlled condition in the OT, and then you perfuse the patient. In uncontrolled death, the death occurs suddenly in the ICU and the home. The problem is we don't have a proper legal framework in which we can just switch off the ventilation and let the patient die and remove the organs. So there is a little bit of confusion over there regarding the legal framework. Second thing is the logistically it becomes a little bit difficult for removing the kidney so fast and putting chances of these things are more common. So it will be better, like Dr. Sanjay sir was saying, that you first focus on living kidney donation, then move on to deceased kidney donation. Donation after cardiac death in India is little bit difficult to pursue. It is done more in European countries, mostly in the Australia and Spain. Thank you.
Thank you, sir.
Yeah,
Sir,
So,
Atlani, sir.
so, Ji, Ji. Uh, I would like to thank Dr. Professor Sanjay Agarwal, sir. We were blessed to have you second time here, sir. Last time you visited last year, and you guided us on the departmental settings and dialysis. As you suggested, sir, the cadaveric donation kidney transplant program is not in very much flow in India, and so we are only left with the living donor kidney transplantation, and which is also being done which is at its plateau in India as well. So we are left with only the new techniques which you suggested, novel ways to increase the living donor kidney transplantations. But you also suggested that these techniques are very costly and the long-term results are still not very much clear. So so the only way which is left with us is to educate more the donors about for the donation, living donation, and so that we can make it more, we can transplant more living donor transplants in India. Thank you, sir. Keep guiding us, keep blessing us. Thank you, sir.
Thank you, sir. So thank you all our chairpersons also. We'll move on to our next session. And to start with, I will I would like to welcome the chairpersons, Dr. Vaishali Vandeska ma'am, Head Department of Anesthesiology, AIIMS Bhopal. Ma'am, I guess ma'am is not there.
Yes, Ketan,
You're
I'm
there,
here.
ma'am? Okay, ma'am.
Yeah,
Okay,
yeah.
ma'am. Welcome, ma'am. Then I would like to welcome our next chairperson, Dr. Saurabh Jain, Associate Professor, Department of Urology, Gandhi Medical College and Hamidia Hospital, Bhopal. Sir, you are there?
Yes, I'm there.
Fine, thank you. And I would like to welcome Dr. Puneet Tiwari, sir, a consultant urologist, MKM Hospital, Bhopal. Sir, are you there? Dr. Puneet Tiwari, sir, are you there? I guess he is not there. Fine, sir. So over to you, sir. Chairpersons, I would like to welcome the next speaker, Dr. R. Manikandan, sir, Additional Professor, Department of Urology, Jipur, Pondicherry. Sir. Thank you, sir.
Hello, good evening, everybody.
Yes, sir. Good evening, sir.
At the outset, I would like to thank the director, AIIMS Bhopal, and the Department of Urology, AIIMS Bhopal, for giving me this opportunity. I would like to express my best wishes for the Department of Urology to start the renal transplant program at the earliest. So coming to my topic today is about the organ preservation. That's with respect to kidney transplant, the need and the technique. So what is the need for organ preservation? See, preservation basically enables us to buy time. So it helps us to transport the organs to the places needed. It can help in preparing the recipient patients, waiting for the organ transplant, waiting for the organs to be procured safely and to be transplanted. So, secondly, the organ preservation is also a major determinant of the graft outcomes after revascularization. So this organ perfusion is a key factor in both the living organ donation as well as in the disease organ program. So basically in organ donation, the organ harvesting, there are two types of ischemic time which has been described. There's the warm ischemia in the donor, the cold ischemic time when the organ is perfused in the bench, and then the warm ischemia in the recipient before the revascularization of the allograft. So basically the methods of organ preservation has been of two types. One is a static cold storage and the dynamic preservation. Dynamic preservation consists of two important technical aspects. One is the hypothermic machine perfusion and this is the normothermic machine perfusion. So first we talk about the static cold storage. Static cold storage is the most commonly performed type of organ preservation world over. The certain types of solutions have been employed in kidney preservation. The first and foremost was introduced was the urocolins in the 1960s and 70s. Later on, we had other preservative solutions which has come into the market, namely the University of Wisconsin solution, histidine tryptophan ketoglutarate solution. These are the two sheet anchors and been in worldwide predominantly used in the kidney transplant as well as in other solid organ transplant programs. The other solutions which have been introduced include the Marshall solution, Belzer solution, Celsar, and Institute Georges Lopez solution. But the head-on-head studies comparing the UW solution with STK solution or the other newer solutions have not found any advantage. And cost-wise also, these two solutions have been the sheet anchor in the kidney transplant and the solid organ transplant worldwide. So in static cold storage, what is the principle is that the organs are preserved in a to reduce the core temperature of the kidney to 0 to 4 degrees centigrade in a hypothermic environment. So the harvested kidney is flushed with the cold preserved hypothermic preservation solution, and then the blood in the donor grafted kidney is completely flushed out, and the organ is preserved in cold solution. So by doing this cold storage, we are able to preserve the organs for at least for 24 hours and then overcomes the physiological changes, pathophysiological changes which can occur during the cold ischemic time. So basically, what the how this static cold storage is going to help in the preserving the grafted kidneys is that the hypothermia reduces the metabolic activity of the kidneys of the grafted kidney, reduces the ATP requirement, and thereby reduces the cellular inflammatory mediated responses in the transplant and the grafted kidney. These solutions have certain important ingredients which maintains the intracellular environment in the absence of the sodium potassium pumps. That is these solutions are rich in potassium, and then these potassiums can move inside the cells and maintain the hemostatic and metabolic milieu. These solutions are have high osmolality, hence they reduces the cell swelling and reduces the organ damage and maintains the graft viability. And moreover, they reduce the free radical reaction and reduces the incidence of reperfusion injury when the organs are transplanted with the recipients. So advantage of the cold storage technique is that they are cheaper and technically easier to perform. But the downside is that there are no standard parameters to evaluate the organ viability after the organs has been perfused, what amount of ischemic damage the organs have achieved. And there are no defined outcomes to determine the predictors of the transplant outcomes in this static organ perfusion group. So there is a research of mechanical perfusion techniques in the recent years, mainly because of the decrease in the availability of the high quality standard criteria donors, that is the SCD donors in the population. With increasing extended criteria donors, kidneys being harvested, as well as the increased instance of DCD, there's a donation after circulated death, which is mainly happening in the Western countries. So now we are having increased availability of kidneys of various criteria. So to make them viable and to achieve the best graft outcomes, the role of mechanical perfusion has increased in the recent years. So the mechanical perfusion was basically first introduced by Professor Belzer in 1960s, where he adapted the technique from the cardiac bypass machine. he developed his own chamber, ice chamber, where the kidney is placed and then the organs are perfused by the mechanical perfusion solution. So the principle is that the kidney is perfused through with a pulsatile cold perfusion solution through the renal artery, and then the efflux is taken out from the renal vein and again circulated by the pump into the kidneys, maintaining a cold preservation solution for an extended period of time. So this ensures that the kidney remains in a well-preserved condition, favoring the transport of the kidney for long distances versus for a couple of or for an extended period of time as well. So commercially available, the kidney available machines have become more and more smaller and compatible and can be used for transport of organs across cities and even across countries. So the commonly available pumps include the RMP pump, the life port pump, and the kidney assist organ assist pumps. So in the realm of the deceased organ donation, the organ perfusion in terms of the brain dead donation, the arteries, in the brain dead patient after laparotomy, the abdominal aorta or the iliac artery is perfused, cannulas are inserted to perfuse the liver and kidneys in terms of when the abdominal organ procurement is happening, and then the vent is created in the inferior vena cava, and the organs are covered with ice, and then the organs are procured after the kidneys have been flushed with the perfusion solution to extract the organs in a good viable state. So when this normotomic regional perfusion is a technique which has been employed, particularly in the donation after cardiac death. This has been found to have increased the graft yield to get more viable kidneys from these uncontrolled patients, the category, particularly the category 1 and 2 of Maastricht classification. They are the who had suffered cardiac arrest in the streets or in the emergency department in the hospitals. Basically, the rapidly cannulation is done in these patients to establish an extracorporeal circuit to perfuse the organs, and a special type of cannula with a balloon is used to occlude the descending aorta to exclude the abdominal compartment to perfuse the solid organs. See, the components includes an oxygenator, the heat exchangers, a centrifugal pump, and an open circuit with reservoir to provide the organs with the sufficient amount of oxygen and the perfusate to maintain its viability. So this was a study which was published in Journal of New England Journal of Medicine, comparing the static cold storage with the hypothermic machine perfusion. The basic downside of the machine perfusion is the cost associated with these machines, as well as the lack of availability across all places. So is there any advantage of a machine perfusion over static cold storage? The study outcomes were interesting. They said with respect to the outcomes, the delayed graft function, it was significantly reduced in the machine perfusion group. The primary non-function was higher, 2 times higher in the static cold storage group, but it didn't reach statistical significance. The graft survival, that is the earlier and late graft survival at 1 year and 3 years, also found to be superior in the machine perfusion group versus the static cold storage group. The subgroup analysis with respect to the expanded criteria donors, also the machine perfusion group kidneys performed better with respect to the early graft as well as the 3-year graft survival as well. This was also proven by another randomized control study, which showed that particularly in the extended criteria donors, the machine perfusion had helped in procuring a well perfused grafts, and the graft outcomes have been excellent over the static cold perfusion groups. So there is renewed interest in the machine perfusion, particularly when there is a donation after circulated death. So this study published in Analysis Surgery also, the authors concluded that the hypothermic machine perfusion was associated with a reduced risk of delayed graft function and better early graft function up to 1 month after transplantation. Hence, they concluded that routine preservation of deceased donor kidneys by hypothermic machine perfusion is therefore advisable. The future directions of machine perfusion, there is a lot of research is going on with respect to the components of the machine perfusion fluids. So now a lot of work is going on with respect to the components in terms of addition of agents which can inhibit the complement mediated injury to the graft, agents which can reduce the vascular resistance, agents to mitigate the ischemic perfusion injury, agents which can improve the grafts by direct gene delivery, and last is the maintenance of mild hypothermia in the deceased donor organs. This is donor itself, which is a new concept is coming in, where the donors are maintained in a slightly hypothermic condition to maintain better blood supply and reduced organ perfusion damage before the organs are harvested. And finally, we need probably biomarkers to predict which organs will have a delayed graft function in the long term. Thank you.
Thank you very much, sir. Over to chairpersons.
Hello.
Yes, ma'am. Yes, ma'am.
Can I audible? Am I
Yes.
audible?
Yes,
Okay.
ma'am. Yes.
Dr. Manikandan, thank you very much for covering such an important topic. Actually, I am having one question.
Yes.
Regarding oxygen persufflation. This is again one method which is available in the books. So I would like to ask you, so whether we are regularly using this machine, this technique for organ preservation.
Organ persufflation has been a technique has been described, ma'am. But if you see the workhorse, particularly with respect to the deceased donor, the donation after cardiac death as well as the after the brain death harvesting, mainly the hypothermic machine perfusion and the normothermic machine perfusion has been the major workhorse in these two circumstances. Organ persufflation, as such, the practicality is very less. Though the literature has also described about it. Practically, I have never seen or had experience with organ persufflation, but I have seen normothermic perfusion being performed in Spain, when I was working there.
Okay, and is there any practice of organ damage markers we are doing before grafting?
No, ma'am. Particularly, it is only in experimental setting, but not in clinical usage.
Good evening, sir. It was a wonderful talk. I just want to ask you one question. While I was in my training for renal transplant with Dr. Rajesh Alawat, we always use chilled ringer lactate as a perfusion solution. And when I was working as assistant professor at ILBS, we used STK solution, custodial solution, as a perfusion solution. At both the places, I found no difference in the patient outcome while using any of these solutions. So what is your preferred perfusion solution, and what is your take on using chilled ringer lactate as the sole perfusion solution?
A very interesting and practical question. If you see the live donor program in our institute and many institutes in our country, the chilled ringer lactate is the most common perfusion solution which is being employed because it is cost effective, and as you said, it has been produced equal outcomes with respect to the HTK solution which is available. There has been a study from Christian Medical College, Vellore, where they assessed the outcomes with respect to the chilled ringer lactate versus the HTK, and they found that the results are equal. The role of HTK comes particularly only mainly in the diseased organ program, where we initially flush the kidneys with about 3 to 4 liters of chilled ringer lactate, followed by a liter of HTK to ensure the organs are well preserved. And basically, in a live donor program, majority of centers are using the chilled ringer lactate solution, and only in a special circumstance, maybe if you have multiple vessels or if you have a expected difficulty in the recipient surgery, we expect a long ischemia time, then probably it is advisable to use a HTK. For otherwise, or for all practical purposes, the chilled ringer lactate is preferred.
So, sir, amongst all this, is there any preferred situation where you will use STK, not use University of Wisconsin solution or Ringer lactate? Like, are there specific conditions?
Mainly, we prefer HTK over Wisconsin solution, but the liver transplant surgeons, they prefer the UW solution. They say the graft flushing and the perfusion injuries are lesser with UW solution. But as far as the kidney transplant is concerned, the head-on-head studies say that the outcomes are of UW versus HTK are equal.
Thank you,
Dr.
sir.
Manikandan, can I answer this question?
Yes, sir. Please.
Okay. So UW and STK, they are, in one basket. And see, except that there are, differences like the content of magnesium and, some ions there. Whereas Ringer's is a very simple solution along with piperine. So to Saurabh, we should not be actually comparing the two. That means UW and STK on one side, you can ask which one of them is better. So there will be pros and cons. But Ringer's is very different. Now, as Dr. Manikandan has very rightly pointed out, whenever you are doing multiple vessels or you expect that's a difficult case, an obese donor, you are going to take longer ischemia time, rewarm ischemia time, then you must use one of the UW or STK. Otherwise, in a single vessel case, and if an experienced surgeon is doing, Ringer's is good enough. But again, for a newcomer, like if I have to mentor, like I go to Jodhpur, mentoring their program, I quite often fly there. So I tell them that you please arrange STK, because if for an experienced surgeon, he can do the things, faster. But when you are mentoring somebody, you are allowing him to do the surgery. So it should be very clear. In a beginning of a program like in AIMS Bhopal, I would suggest that they should be ready with STK or UW, which are more or less equivalent, not talking about liver versus kidney and all, but STK and UW on one side of the balance and Ringer's on the other side.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you very much, sir. Now, I would like to invite Dr. Anish Srivastava, sir. He has been very busy. He was live somewhere else on a webinar of robotic program, and now lately he has joined us. So welcome, sir, and over to chairpersons. Sir, you can start your slide, sir.
Yeah, so I have, I said share screen. So has Manikandan stopped sharing his screen? Because
no, Anish, you are on a whiteboard. Go to the screen. When you do share screen, there are lots of frames will come. So you are on the whiteboard.
okay. Because generally it would straight away come.
Then wherever your slides are, you move that.
No, my
frame.
slides are open, sir, on the
taskbar,
on the desktop.
Yeah.
And generally they should have stopped straight away. Should have come. Should I stop share and then come again? Or?
But you will definitely, this happened with me because it goes to whiteboard.
Yes, sir. That's what I'm just wondering, why it has got to the whiteboard. And I think I'll go for the stop share and then come back again. Is that all right?
That should be better.
Yeah. Stop share, then I again share the screen, then share.
Again.
Whiteboard, it is coming. It's all whiteboard here.
So what do you see on your screen, Anish?
The whiteboard, and then there are on the top columns like, but nothing.
So if you change from whiteboard to other columns, you will see the screen. Take your cursor on other boards and press there.
Remote control.
Because by default it goes to whiteboard.
Manoj is trying to help me out. I think.
Give the remote.
Yeah, he's going to he's going to control that.
Thank you, sir. So it is not possible from this side.
Okay.
You have to open your PPT, sir.
I'll go back and again join again.
Please, sir.
Dr. Manoj, you can ask him to share his slides to you in case next time also.
Yes, sir. Yes, sir.
Yeah.
Sir has joined.
No, yes, sir. He joins.
The problem would be the same because he has to do. I had the same problem.
I think Dr. Manoj, Ketan, you ask him to say,
Yes,
email
sir.
immediately.
Sir, Dr. Anish Srivastav, sir, can you mail the slides to me, sir? Sir, am I audible, sir?
No, he's mute.
He is mute, but he might
Yes,
be
yes.
listening.
Yeah, I can hear.
Yes,
so
yes,
I'm going to mail them to you. Okay.
Yes, sir. Please, sir. Please, sir.
That will be best. Yeah, that is the
generally it should not have happened, but I don't know. Anyway, I'm going to mail them to you.
Please, sir. Sir, are you there, sir?
Mute button.
स्क्रीन में आएगा ना ऑडियो आ रहा है क्योंकि म्यूट है
So I mailed them to Syed that
yes, sir.
I mailed them to Syed, who the one who sent. I think somebody else.
Emailed to probably to wrong address probably.
Sir, it is, sir, urology@aimsbhopal.edu.in, sir.
He has sent somewhere else.
Dr. Ketan,
Yes, sir.
finished?
Sir, I am still waiting for the slide, sir.
Okay. Yeah, just went for some time. Just asking whether it's finished or it's still going on.
No, sir. One presentation is running. Just excuse me,
Okay.
sir.
Okay, no problem.
Sir, you can mail me at
क्या बोल रहे हो?
Ketan, write email in chat box. Then he can see it easily. Just drop it in chat box.
the slides will be there, sir, in a few seconds. Yes, sir. We have got the slides. So within a few seconds, the slides will be online. Yes, sir.
Okay, so
Yeah, I'm going to.
am I? Yeah.
Yes. Just give me a few seconds, sir. Are the slides visible, sir?
Yes, yes.
Yes, sir. Thank you, sir.
Okay, so do you want to make it full screen?
It is full screen, sir.
Okay.
Dr. Ketan, you have to start the slideshow.
Yeah, that has started, sir.
No, it is not
No, Dr.
slideshow.
Ketan, still it is not started.
I will 1 second.
It is not slideshow. It is
To
just
the slideshow.
Yeah.
Okay, fine. Fine, sir.
Okay.
Shift F5.
So if it's still not full screen, but anyway, we can. I think.
Shift F5. Just press Shift F5.
Shift F5. Yeah, I'm doing it, sir. Is it visible, sir?
Yeah, to me it is visible, but it's not on the full screen.
Ketan, Dr. Ketan.
Yes, sir.
You see, you are seeing on the above the slide, enable editing. Just click that enable editing.
Oh, we'll do it.
Enable editing, yes.
There is a yellow bar on top of slide which
Yes,
shows
sir.
enable editing. Just click enable editing.
Not.
I think right lowest corner you see there is a sign. Yes, that's one. Just no. Just on the right side. No, on the right. Yes. No. 17. Just to the left of 79%.
Yeah, this I have done, sir, but it is coming like this only.
Yes, but you click enable editing.
Unless
Enable
you
editing.
enable
On the
editing,
top,
you will not be
there is
able
a
to.
yellow bar.
So I'm sharing for it. Sharing here is the
But it is the same, sir.
same thing. I'm sharing for you. Is it okay, sir?
Now you do.
Yeah,
Now it is fine.
Yes.
Good.
Yes, sir.
Great.
So really.
Thank you, sir.
It's always teamwork, sir.
Yeah, thank you, sir.
Actually, I did 5 webinars this week, so I sent it to somebody.
Unless you do enable editing, it will not allow you to function.
Thank you, Dr. Agrawal.
Thank you, sir. Thank you very much.
Good evening, Anish sir. Yeah.
Okay, so thank you, Professor Sarman Singh, the director of AIMS Bhopal, and the Bhopal Urology Society friends from Bhopal. It's a very unique and emotional moment for me with Professor Mahen Bhandari, who has been my philosopher, mentor, and guide, to be in one of the audience. It matters a lot to me. And he always used to say that, Anish, for last many years, you have been going around lecturing and all. I keep seeing you. And he always used to encourage me. And whatever I am today is all because of him. So, and then it's a moment where I could catch up with Dr. Atlani, Santosh, Saurabh, Puneet, and so many friends from Bhopal. So today I'm going to talk about the complications. And first of all, I must compliment the man who actually gave this title of QYV. This is actually what it should be in renal transplant. There should be absolutely no complications. We all know for donor, but again for the recipient, besides certain inherent things, inherent issues with the recipient, but from the surgical or from the medical side, we should look at zero complication rate. And therefore, anticipating and preventing the things is important. Next slide, please. So now the surgical complications could be basically related to the graft and the vessels. And then there would be peripheral issues like the ureteric complications, the complications occurring with the various other peripheral organs. So I have basically divided them into two. And here I would be talking mainly about what happens when you do the anastomosis and then you open the clamps. Next one, please. So this is what all can happen. We have seen all this happen and how we can prevent, because the first complication is a nightmare. It is a disaster. So we'll take them one by one. Next one, please. Next one, please. So this can happen in a patient who is very obese, has a very bad lipid profile, and diabetic. They would have extensive, they can have extensive mural calcifications. The issue is the external iliac artery and the internal iliac artery where you put the graft may be totally bad. Internal iliac is the first to get occluded, and then you need to put the graft only on the external iliac, and that too taking precautions. So if you, yeah, please, next slide, please. If you have a non-contrast and then a contrast CT, see in ESRD, you can always do a contrast CT and just follow it with a dialysis. So if you do like this, then as you can see here, there are areas which are actually uh, uh, relatively free. And that is how you have to make sure. Suppose there are a lot of calcifications on the left side, and it has happened with the transplant surgeons. They have gone in and they have not been able to find a plaque-free area. Sometimes they have done transplant into that, and then after opening the clamp, a dissection has occurred. So therefore, it is very important to choose the site and a site where the artery is less likely to have any of these things. Next one, please. This is one paper from one of my friends, Dr. Murthy from Nizams. They said that, you know, if you do a good Doppler, probably it can help. But I differ from the views here. Even we have done Doppler, and still we may not find, you know, the Doppler will not show that kind of calcification which can be detrimental to the graft. So I would still say that in a high risk group patient, preoperatively must do NCCT and a contrast CT to select the site. Next one, please. Now, if it has happened, the next thing is it has happened. Then these are the series which are showing the various kind of things, the intraoperative management. One might need to put a PTFE graft and, you know, the metal stents and all kinds of things. I'm telling you, if this happens to anyone, it is a disaster. It's a nightmare. Then you may, you know, sometimes have to go on to the other side, put the graft and all kinds of things, revise your anastomosis. But the fact remains that the external iliac artery is gone and the limb circulation may suffer. So therefore, this is very important. It may happen rarely, but then it is there. Next one, please. So these are the, again, endovascular stent placement and all. Next one, please. Just to take care of, you know, to reconstruct the artery. But then after reconstruction of the artery, sometimes on the PTFE, the graft has been put. But as you know, this is a compromising situation. Next one, please. Now, second thing is, next slide, please. If you see here, the area where the surgeon has put a bulldog clamp. There are some surgeons who are in habit of putting a bulldog clamp on the renal artery. This is an anastomosis being done with the internal iliac. And then they, you know, infuse some saline at the end, and then they check the leakage. But I would suggest that one should never put a clamp, any kind of clamp on the renal artery, because even that can rarely give you problem. Next one, please. So this was about the arterial thing. The another issue could be with the venous outflow obstruction. And these are the things which might happen. And again, we need to anticipate. If you are not very careful, like if I say the inclusion of the valve in the cusp of the anastomosis, if you find a big valve, then it must be excised. If you try to do an anastomosis without properly taking care of the valve, the moment you open the clamp, sometimes there can be issues. Then while you are doing anastomosis, make sure that the other side is free. And most important thing is, I will again reiterate, again insist in my future slides that the vein on the right side could be treacherous. And it is very important that you take, preferably take a cuff of IVC and then do it. It is especially important for the beginners. The masters and the champions can do anything and get away with. But this is the fact of life, that when we are in the beginning of the program, we must take a good cup of inferior vena cava, whether you do it open way, the laparoscopic or robotic, that's immaterial. Because this is something, as I'll show you in the next slides, that again, it could be a nightmare. Next one, please. Next one, please. So this is, see, one kidney which long ago we had, and the cuff was not adequate. Sometimes you can do many times. You can get away if there is a long right renal vein in many situations. But in an odd situation where the right renal vein has already gone into the hilum, then it needs lengthening procedure before doing the transplant, and saphenous vein is one of the options, as I've shown it here. Next one, please. And this is how it has been put. Next one. And then you can see that, you know, the kidney has been salvaged. Next one, please. So again, it is you know, the preempting and the and anticipating the problem is very important, rather than doing the transplant and then realizing or regretting. Next one, please. This is another set of candidates or things which can happen where you open the clamp and there is a potential for kinking of the vasculature. So again, preempt, and don't do a too distal venous anastomosis even while putting an incision. Be careful. So those are the things which one has to take care. Again, prevention. Now, you have done a good satisfactory transplant and you are sitting in the coffee room and they are closing. You have done the ureter also, they are closing. The output was good. And the resident comes to you and says, sir, we have done the skin sutures as well. And now there is no output. Absolutely. Now what might happen? Now these are the two situations which all of us should know, that a kidney get compressed because we are putting it into a potential space, which is a retroperitoneal space. Next one, please. And this is what is known as the compartment syndrome. We'll not go into details. We are already running late. Next one, please. So this is what happens to the blood supply when the kidneys gets compressed between the peritoneum and the abdominal wall musculature. Next one, please. And these are the studies where either you are trying to put a big kidney with a big adult muscular adult and a big kidney into a small, you know, fossa in a female or in a pediatric patient, then you have to preempt. Again, next one, please. So these are the situations, and a good rectus relaxing incision can help you out. Don't think that, you know, after some time the diuresis will start. If it has happened like this, people say that I'll do it ultrasound. Ultrasound may show, Doppler may show some blood supply, you know, unless the arcuate vessels it gets compressed to the extent that the arcuate vessels are not seen. Then only ultrasound is 100% specific Doppler. We must go by clinical. Why should a kidney which was diuresing very well should suddenly stop giving you even a single drop of urine output. These are the various ways where you can put the kidney once again, make it comfortable, and nothing will happen. Next one, please. Now, this is another thing. Sometimes while we are retrieving the kidneys, the capsular tear occurs. Now, while we are doing anastomosis, we should be careful and look at if there has been a hematoma or a blood going beneath the capsule. And this is a kidney which I am trying to show, that if you find a hematoma like that, and if you find that it has expanded even a slight bit, don't leave it alone. Give a generous capsular incision so that all the blood is drained out and you will not have any issue. Because if you leave it alone at that time, you close, then the blood is going to go gradually seep and dissect the capsule from the kidney cortex, and then the kidney will stop functioning, and this becomes a page effect, and this kidney, if left alone, can become non-functioning, and this would be a graft loss. So that is how we can preempt and prevent this complication. Next one, please. So then once the patient is wheeled out and he is well into the post-operative room and all, then these are the issues which can occur. Next one, please. Post-operative bleed. You get a call again, you go home and you are taking your dinner and all, and then they say the call is there, and the patient has hypertension, again stopped urine output. So the first thing is again to check the catheter and all that exercise. And these are the things which we have seen in our experience. And I don't think that we should, in such cases when there is, when you know that there is hypertension and the urine output has dropped and there are issues, drain, I would warn you, drains could be most deceptive, because in case of heavy sudden bleed, they might get blocked. Do not depend on the drain. The resident might say, sir, but the drain is dry. No. Look at everything. If you have a quick ultrasound, do it. You will see a lot of hematoma around. Go in. And these are the things which we have seen can be taken care. Next one, please. This is something, next one, please. Yeah, this is a case where everything was fine. And then this scenario of graft rupture, which I'm going to tell you, it used to happen earlier, even before maybe with the tacrolimus era, or now we have got very sophisticated cross-match techniques. We have flow cytometry, and we go to the last exam and the single bead antigen, and a lot of things from our nephrology colleagues to make it safe. But earlier we used to see this kind of preformed antibodies and the antibody-mediated rejection, which can cause the graft rupture sometimes, which again is a catastrophe. We have done many nephrectomies in the past, Dr. Sanjay and Dr. Guleria would remember, but now it doesn't happen. And even if there is a graft rupture, in a case, maybe in a AVO incompatible or some transplant, it can still be repaired and managed. Next one, please. Next one, please. This is a case where we could salvage the graft. Next one, please. And these are the guidelines where, if it's a life-threatening situation, then I think graft nephrectomy is better. Otherwise, you can suture and try to preserve the graft. Next one, please. This I have taken from the literature. In an extreme case, the surgeon had to resort to glue and covering with polyglactin just in order to save the graft. But then recurrent rupture can also happen in a bad situation. So it has to be weighed. Next one, please. Now, another nightmare to the surgeon is this, and these are the predisposing factors. Again, if the patient is falling into one of these categories, please be careful. And next one, please. These are the factors. If the patient is more than 45 years, no family history, but then you find out that he has got many scars in his arm, and he had recurrent failures. Then we need to do antithrombin T, protein C and S. If there were histories of venous thromboembolism earlier, then factor 5, and accordingly antiphospholipid antibody. Again, to prevent any kind of catastrophe, and mTOR inhibitors as immunosuppressants would help. Next one, please. Now, this basically is an uncommon complication, but this is how, in the post-op, again, maybe on a day or next day, everything is fine, everybody is happy, and then the previous hour, the urine output was 500 or 1,000. In this hour, it is 20, 25 ml or maybe 0, depending on the native kidney output. So this is what you must immediately think about. People have given the streptokinase injections and all, which the cardiac surgeons do for the acute MI-like situation. But most of the time, by the time we diagnose, the graft is lost and nephrectomies, most of the times, But you can still salvage. And there are occasions where if you can wheel the patient inside the theater immediately, this will happen only when you know. And if you wheel him in and go in and do a good thrombectomy, again, probably you can salvage, but practically that is very difficult. Next one, please. So high degree of suspicion, and a team which can actually, like a crash team, take the patient into the theater, and then probably you can salvage. Otherwise, it is difficult. Next one, please. So here you can see external iliac artery and a stump coming out of it. This is a artery where there was a thrombosis. Next one, please. Next one. This I think. So we come to the vein thrombosis. Again, reiterating the same point. If you go through the literature, everything happens 99% on the right side. And therefore, we need to be very, very careful. And I have already, I think, highlighted the points, taking a good cup of IEC. And again, I would say that the champions can do anything. But for the beginners, it is always better to go slow, take a good cup of IVC, and then do a good anastomosis. You will not have any problems. Next one, please. Again, I think the same thing. Next one, next one, please. Yeah, this is all how we diagnose the renal vein thrombosis, reverse diastolic flow. Next one, please. Next one, please. Again, next one, please. Graft rupture can happen because of the high pressures inside, early diagnosis. Next one, please. So people say, why not give heparin to everyone? So we looked at the literature, and it is not actually required to give heparin to everyone, except in these select circumstances where you think that this could be a high-risk candidate. You should give heparin to the recipient. Next one, please. So this is a case, where we had to take this out and the graft in the basin. Next one, please. Now, these are other things. Next one, please. So renal artery stenosis. And again, this could be, from weeks to months. And generally, it will be around 6 weeks to 3 months time. Patient would be presenting with a escalating need for antihypertensives. That is how your nephrology colleague would give you a phone call, and deteriorating graft function. Next one, please. So this is again one of the complications which is preventable. Next one, please. So we can have stenosis at these areas as shown here. Next one. And most of the times we can actually, if it is very early, then you can go back and revise the anastomosis and all. But if it is late, when there are factors like immunological injury, donor or recipient atherosclerosis added along with the trauma or a badly done anastomosis, then this can happen. And then I think next one, please. Then only your radiology colleague would come to your rescue. Next one, please. Yeah, so Doppler ultrasound will give you the diagnosis. Next one, and then a CT angio. Next one, please. Now, a very important point here. Sometimes you might get false alarms from the radiology. The patient has got, the nephrology colleague says that, the antihypertensive requirement has gone up slightly. They send the patient for the Doppler and you get a report. Now, the important thing is that systolic velocity could be anything from 200 to 400. So unless you have a lot of parameters to support your diagnosis for renal artery stenosis, don't be swayed and don't take odd decisions. This happens between the nephrologist and urologist. We have seen a lot of it happening occasionally, sometimes more, heard from the colleagues, and people have gone in and opened and again to find, that there was no stenosis and it was an unnecessary exploration. So point is that radiological investigations must be interpreted cautiously along with the clinical acumen. Next one, please. Now here you see, next one, please, the stenosis, and next one, please. And you will see the small segments. Next one, please. The balloon dilatation being done. Next one, this is one of our patients, and on the external iliac artery. Next one. So after, you can put in a stent also. Next one, please. And then so these are the various ways. Next one, please. Now, this is again a nightmare. This is a pseudoaneurysm on the site of anastomosis on the external iliac artery. Extremely rare. Most common cause, if it could be a stitch while you're taking a suture between an adventitia and intima, and then there is a site of leak. This is how a pseudoaneurysm forms. You are lucky if it is just a pseudoaneurysm, but if it is a mycotic pseudoaneurysm, which you need to check with the fungal cultures and looking at the size, the way they grow, then that's it. That's a disaster. A mycotic aneurysm means it's a loss of the graft, sometimes even loss of the limb, or maybe even the patient. So therefore, as a surgeon, we must make sure while taking sutures that we take intima and adventitia both. If you are not sure, you can revise the anastomosis, you can redo the suture, but this is one thing which might happen, only once or twice in your lifetime, but then that would be a big deterrent and a very depressing thing. Next one, please. So these are the options and various theories, but for a surgeon, the suture technique, that is in his hands. Rest of these things are not in his hand. Next one, please. So these are the treatments. If it is non-mycotic, you could go for organ repair, endovascular, or even thrombin injection. Next one, please. But if it is mycotic, then there are issues. These are the various series. Next one, please. These are the indications for surgery. Next. Otherwise, you could do. So this 8 years ago, or this is about 10 years old data, where, so whatever I'm talking about is based on this experience of about 3,000 transplants, 3,000, more than 3,000 now. And this is the data from the initial 2000, where we learned a lot. When you do an audit, when you look back, what all has happened with you in the past? Why did this particular thing happen? And when you look back, introspect, look into your own weaknesses, that is what we have done here. And then I'm proud to tell you that in the last 7 years, my residents, faculty, everybody will vouch that we have hardly had any problem in last 7 years. So that's the point which I want to drive across. Next one, please. So then quickly about because it's going to be a long time, dinner time for everyone. These are the ureteric complications. Very important point. I will stress again. Next one, please. If you maintain the golden triangle while retrieving the kidney from the donor, none of these things would happen. I know it is easier said than done, but and I have seen many surgeons who do not respect, and then they say nothing happens. But then it is not only an early complication like a leak. which can tell you what you have done. But then there could be issues like stenosis in the late post-operative period because you have not respected the golden triangle, and now there is ischemia at the end of the ureter, and then which could lead to stenosis and issues. Even 2 years, we have seen 4 years, 6 years down the line. So as a surgeon, again, prevention and a good technique, that is what is in our hands. Next one, please. Next one. So we did a lot of studies right from earlier, and we are proponents of DJ stent. I know it was debatable, but now it has come in the Campbell's textbook. In the last slide, which I showed, is from the textbook of urology from the Campbell's, which says that now there are double blind, there are there are meta-analysis and everything which supports a routine use of DJ stent. This debate has practically ended, but still I know there are surgeons who do, and I don't say, I still say it could be individualized, but that is what the evidence-based literature says. And for a new surgeon, I would say that you must use a stent. Then we worked on how long it should be put, 2 weeks versus 4 weeks and stuff. These are the papers. Next one, please. And this, then again, sometimes back in 2012, I went back to the data looking at the laparoscopically harvested kidney versus the open surgery. Was the incidence of the ureteric stenosis or leak higher? That was my question, which I answered. And this is what it is, that if you put a routinely a double J stent, it does not matter. A stent, mind you, dear friends, can help you only if you have taken good care of the golden triangle. If you have not taken good care or preserved the blood supply of the ureter, even the stent might help you to some extent for a small leak and stuff. You can put your catheter for a longer time and sail through the crisis. But otherwise, if it's a big leak, then you need to go for a PCN and then maybe sometimes revising the anastomosis. Next one, please. So this is a leak here. Next one, please. This is a stenosis here. Next one, please. And being endo-urologically being managed, we have good results. Some cases from our own. In the past, as I said, in last 7-8 years, we have not seen, touch wood, any major complications. Next one, please. Sometimes we have done now 150 of these transplants, and 2 of these cases, we, despite all precautions, all good preoperative immunosuppression, everything, we had to resort to graft nephrectomy. Another thing which I noted that, because as I said, in last 7-8 years, I was not having any ureteric leak. Then I found patients with some ureteric leak, either small leak, which could be managed conservatively, or a little bigger one where we had to resort to PCN, re-stenting. Fortunately, no revision of anastomosis. Then I look back again at the data. Next one, please, which is here. I was supposed to present it in the AUA this year, but we all know we didn't go to AUA, and this is the paper. Very well done, statistical case-controlled analysis. Next one, please. Just to, in short, the conclusion is that if you have a patient who has been given heavy immunosuppression, either because he was ABO incompatible or he had acute or antibody-mediated rejections, the chances of ureteric leak would be high. But stenosis was not an issue. Next one, please. I think the last thing, we were looking at the lymphoceles and, which are basically the lymph collections around the transplant. Next one, please. Earlier, we used to do them in an open way. Incidence was about 6% or so. There are various factors which will not go into details. This is laparoscopic deroofing, which you can do in most of the cases, unless it's an inferior medial kind of lymphocele, which is onto the vessels and small, then probably you need to resort to open surgery. Next one, please. then this is another thing which can happen. These are the factors. Next one, please. And there are two kinds of incisions. So I will say in short that the incisions which are, little more medial and pararectal, where you don't cut the obliques, the internal, the external, and the transverses, and you are a little more medial towards the rectus muscle side, reflect the rectus muscle, then those incisions are less likely to have postoperative hernias. Next one, please. This is very rare, but again, if you miss a peritoneal breach, like, generally it's the residents who make the fossa, and while, retracting the peritoneum, if they if there is a breach and you are not able to, if you either missed it or if you have not closed it properly, then sometimes we have seen, very rarely bowel coming out of it. And one day, one of the occasions many years ago, the resident told me, "Sir, I am feeling bowel beside the kidney." So I actually laughed, rebuked, and I thought he was joking. But then this was a fact. Then we opened, I put the hand, and then we immediately opened, and then we found that there was a rent which they had in a very obese patient. They were not able to close it, and the bowel had come out in, adjacent to the kidney. Next one, please. So I think, thank you very much for the patient listening at this hour. Thank you.
Thank you, sir. Thank you very much. And thank you, Manoj, sir, for maintaining slides. Sir, over to chairpersons. Vaishali Madam, Saurabh Jain, sir.
Good evening, sir. Thank you for the very nice presentation. Sir, I would like to get your take on your technique. Do you change your technique when you encounter a block in the external iliac artery? Like, do you go inside out from the external iliac artery, or you go outside in? Like, is there a change in your technique?
Yes, Saurabh, I think that's a very pertinent issue. And generally, as I said, if you are well prepared and if you find a soft segment, then there's not an issue. Then there is a CT needle. So now, in such cases, there is a specific needle which our cardiothoracic surgeons do for their, because they are mostly dealing with these kind of vessels in their thing. So that is the one which you could use, and then yes, you can reverse the technique of your anastomosis. Instead of outside in, go inside out. And those things help. Yeah, good.
And sir, one more thing, like many a times ultrasound as a screening modality for iliac vessels is many a times it can be deceptive. So do you routinely add CT scan for evaluation of recipient in your practice?
I emphasize this point right in the beginning, that in a high risk situation, in an obese, in a diabetic, a patient who has got bad lipid profile, please do not rely on doctor. Do an NCCT and even a contrast CT if you want to, nicely delete it.
Thank you, sir.
Anish sir, there's one question from me also. Anish sir, is Dr. Santosh from Bhopal.
Yeah, Santosh.
Sir, good evening, sir. कैसे हैं sir?
बहुत
अच्छा. Sir, this was regarding the imaging before the transplant. Like you said, in the high risk individual, like patient who are diabetic and long standing on dialysis, we do a contrast CT. But we have also encountered situations in which the Doppler was deceptive in relation to the external iliac vein, and Doppler was normal, and we did not get a CT done, and it was a non-diabetic young patient. And when we opened it, the vessel was completely obliterated. Then we had to open on the other side. So I think when there is a history of femoral vein cannulation for a long time, then we should especially look for the external iliac vein caliber on the Doppler, because sometimes in Doppler it is missed. We have missed 2 times, and we had to do the transplant on the other side because radiologist missed the narrow caliber external iliac vein.
Yes, you are very right, because I was focusing basically on the artery, and you have very nicely pointed out about the vein. Yeah, this has happened occasionally with us also. And, so those patients, as you very rightly said, who have undergone multiple n number of times, dialysis through the same fossa, either we avoid or we study them very well. So it is important. Yes, this is what today's seminar was about: preemption. How not to make any complication. Yes, very right. Good.
Thank you.
Thank you, sir. So we'll move on to conclude the webinar. The last presentation by Dr. Manoj Biswas, Associate Professor, Department of Urology, AIIMS Bhopal.
Thank you, Dr. Ketan. Am I audible?
Yes, sir. You're audible, sir.
Good evening, everybody. Warm welcome to all the speakers, chairpersons, and the audience from AIIMS Bhopal. I will not take much time. We are running late. The renal transplant at AIIMS Bhopal and its future. Before proceeding, we should know the history. As AIIMS Bhopal is one of the 7 AIIMS Apex Healthcare Institute, and in the first academic department started in September 2012, and the first postgraduate course started in January 2017 in AIIMS Bhopal. Now come to the mission of AIIMS Bhopal. The mission is to establish a center of excellence in medical education, training, healthcare, and research imbued with scientific culture, compassion for the sick, and commitment to serve the underserved. So, in this motto of to serve the underserved, we are working in that line, the urology department, in trying to develop the department. The urology department is very new to the AIIMS Bhopal. We are the 2 faculty members, myself and Dr. Ketan, working here. But the transplant team is well established here. We have the nephrologist with us who is running the dialysis center very nicely. Along with that, we have the department running with the transplant anesthetist, pathologist, microbiologist, radiologist, and as well as nuclear medicine department. So, before proceeding, we should know the prevalence of CKD in Madhya Pradesh. As we all know, the worldwide CKD incidence is near about 10%. And in India itself, it is 13 to 17%. While in MP, it is more or less the same, 10% to 15%. The etiology of CKD varies considerably throughout India. It varies from state to state. The maximum number of CKD patients with unknown etiology find it Andhra Pradesh, Odisha, and Goa. So the treatment is again the renal replacement therapy, but it is very astonished. 90% of patients requiring renal replacement therapy in India die because of inability to afford care. Mainly because of the financial reason. 60% stop their treatment because of the financial reason. So the transplant practices are dependent on state welfare funding, brain death declaration practice to start the disease donor, personal religious beliefs, and ability to technical expertise and expensive immunosuppressive medications. So as the prevalence is 10% to 15%, we should know the population. The Bhopal population itself considered near about 23 lakhs, and the surrounding area like Vidisha, Sagar, it constitutes near about 10 to 15 lakhs. So such a huge population with an prevalence of 10 to 15%. There should be a good transplant center to handle all these patients. So what are the various transplant centers in Madhya Pradesh? There are 13 recognized centers as per the NOTO in Madhya Pradesh, 8 were in Indore only, and 4 in Bhopal. Among those 4, 2 are doing the transplant regularly. As per the data from the NOTO, it says there are only 7 transplants, living transplant done in 2018 in Bhopal, while in 2019 near about 15 to 20 as per the NOTO. Now come to why transplant program in AIIMS Bhopal. As it is a central institute with well-trained faculties and it is governed by the central government. And we know very well that the financial status of Bhopal and nearby population is very less. The per capita income of the Madhya Pradesh, the ranking is at 27th rank. And the rural to urban ratio is same to the India, as India it is 72%. As we all know the costing of transplant is too high. If it is started in AIIMS Bhopal, we can cut short those costing because of all the subsidies which we get from the government. So AIIMS Bhopal is having a very good scope to start the transplant program for handling all those kind of CKD patients. What are the aims for the future development? The main aim is to start the renal transplant program at AIIMS Bhopal as soon as possible. We are already in the process to get the license. The first is to start with the living donor transplant. After with well-established living donor transplant, we can move to the disease donor. And it is the requirement of the time, because we all know there is requirement of near about 1.5 lakhs to 2 lakhs per year transplant in India, while only we are performing 6,000 to 7,000 transplants at a time. So that can be overcome with disease donor transplant or to motivate the person for living donor. As per the Bhopal traffic police statement, there are about 3,500 accidents were reported in the city in 2018. Among them, the total 350 people died. All these can be used for as a disease donor or cadaveric donor transplants for kidney as well as the liver. Now come to the ideas to increase the kidney transplantation. First of all, to increase the communication and publicity to promote kidney donation. Second, public education about ease and safety of both living and diseased organ donation and preemptive kidney transplantation. That is very important. Adoption of programs such as involving driver's licenses with designation of a presumed willingness for donation after death. That can be motivated. The nationwide national kidney registry is very important to start with, having a computer-based matching for donor and recipients, encouragement of altruistic kidney donation, the use of social media to connect those in need of a kidney with potential donor. I want to conclude here, but before concluding, I want to say thanks to our respected director, sir, for giving us this opportunity to conduct this webinar of a renal transplant. Besides his guidance and support, we could not make this. I would also like to thank Dr. Mahendra Bhandari, sir, for giving confirmation and supporting this webinar. I want to thank Dr. Sandeep Guleria, sir, to share his knowledge at his platform. He is the person from whom I learned the renal transplant. Whatever I did earlier or currently doing in renal transplant, that is only because of Guleria, sir. Thanks a lot to my mentor. Last but not the least, without support of Professor Dr. S.K. Agarwal, Dr. Pranjal Modi, Dr. Anish Srivastava, Dr. Manikandan sir, and Dr. Dorajan sir, this even could not be possible. I would like to thank our chairperson, Dr. Anit Arora. She is Dean Academics. Her support and guidance always help us to grow. I would like to thank Dr. Ashwin Tandon, Dr. Mahendra Atlani, Dr. Sunil Tejpal, Dr. Vaishali, Head NSA Department. I would also like to thank Dr. Santosh Agarwal, Dr. Preet Tiwari, Dr. Saurabh Jain, renal transplant urologist at Bhopal to chair the sessions. In the last, again, I would like to thank Dr. Ketan for smoothly moderating this webinar. Thank you all.
Thank you, sir. Thank you very much, sir. So the crux is the motto of our director, sir: energy, hard work, and consistency. And the motto of our and the teaching of our Bhandari sir and all other mentors: sustainability, quality, and patient care. I hope after this good and knowledge gaining webinar, we will be able to start and sustain the transplant program at our institute very soon. So it was a very good webinar, and during this time we forgot that some microbe is dancing outside waiting for the people, and I guess we will be able to conduct such webinars with the blessings of all the mentors, Sarman Singh sir, Mahendra Bhandari sir, Sandeep Guleria sir, Pranjal Modi sir, SK Agarwal sir, Manikandan sir, Anish Srivastav sir, and all the chairpersons. So I would ask permission of director sir and all mentors, and we will conclude.
Thank you, Ketan. Very nice, and thanks once again from my side also to all the speakers and my old colleagues, present colleagues. Thank you all. Thank you,
sir.
Thank you, sir.
Thank you, sir.
Thank you.
Thank you, sir.
How are you?
Thank you, sir. Thank you, sir.
Thank you. Bye.